Hello and welcome to our workshop on cognitive therapy for PTSD. The focus of this workshop is to give you an overview of the cognitive model of PTSD that forms the basis of this treatment and also guides the therapist throughout treatment in formulating the patient's problems. This one-day workshop focuses on the therapeutic procedures that we use to address the patient's re-experiencing symptoms, the memory work. This in practice is closely intertwined with the work on the problematic appraisals that maintain the patient's problem. But you will find more detail on the cognitive procedures that we use for restructuring these appraisals in other videos. Because re-experiencing symptoms are so central to the understanding PTSD, we wanted to have enough time to really take you through various examples of this work. The workshop will give you examples from sessions in face-to-face therapy. Obviously now in the current circumstances, many of you will be working remotely with patients. You will find detailed guidance in how to use these procedures remotely in the COVID part of our website. There is various webinars, papers and also video examples that will guide you through the remote working. On the website you will also find materials that we use in treatment, both questionnaires and other materials. The questionnaires include process measures that we find very useful to track the patient's progress through treatment, such as a measure of appraisals, a post-traumatic cognitions inventory, and other core measures that measure the processes we are addressing in treatment, the quality of the memories, and also the responses to intrusions that patients show, and safety behaviors. Furthermore, that you will find information sheets for patients and significant others, various recording sheets for behavioral experiments or hotspot updating, and a blueprint. Okay, let me start with talking just very briefly about what we know about post-traumatic stress disorder and how this has influenced our thinking about how we should treat this disorder. You will all be familiar with the diagnostic criteria, and they have changed over time. There's always some element of definition of what a traumatic event is in the diagnostic criteria. Currently, it has been widened again in the DSM, but I think at the core of it is usually there is some threat to physical integrity or to life, that either for the patient themselves or to other people that is involved. It can also be there are also some events, for instance, that people who work as first responders or in emergency services or police and so on repeatedly observe that then can, in the accumulation, lead to PTSD. But the most common is that the most common presentation is that it was a threat to the patient's life or physical integrity. And we tend to define traumatic events quite strictly. So if somebody has is going through a very upsetting divorce, we wouldn't really expect the same kind of symptoms to, it's obviously very stressful, but we don't need the special memory techniques that we're using for PTSD in that disorder, after events like that. What stands out in the definition of PTSD are the re-experiencing symptoms. The patient will re-experience part of the event in a very vivid way, and we'll talk quite a lot about re-experiencing today, because I think that's really the crucial symptom that we want to target. And understandably, if people have these very upsetting re-experiencing symptoms, we will also avoid reminders of the trauma. They often have symptoms of numbing or loss of interest that overlap with depression. In DSM-5, we also now have a category that combines changes in mood with changes in cognitions. Cognitions are very important for our treatment as well. and hyperarousal symptoms such as startle responses, being hypervigilant. But I really like to focus on the re-experiencing symptoms here. So what are the re-experiencing symptoms like? I think the most common type of re-experiencing are very brief memories that pop into people's mind of either like images or sounds or smells or other sensory sensation from the trauma. They can be quite brief, but still very distressing. It can also include physical sensations, so people can have the pain they experienced in the trauma again, or if somebody was unconscious or as in part of the trauma, they may really feel faint, as if they were going to faint in the session. So that's something to watch out for. And it can include any kind of gestures or flight response, so people might suddenly leave a situation. And what is interesting about is that even though these are memories, people often have the sense that it is just something that's happening very much in the here and now. So that's the one characteristic I would highlight. These intrusive memories or other re-experiences have this really subjective sense, it's happening now, what I'm perceiving. In the extreme, it can be a full-blown dissociative flashback, where people really are back in the situation and really behaving like they are back in the situation. And that can be, I think, is something that therapists are quite wary of. They don't want to induce flashbacks, of course. And we'll talk a bit about dissociation later, how we can spot it and how we can help the patient engage productively with the trauma memories and not induce a flashback. But the sense of nowness is really very clear in the flashbacks. For instance, we had a patient who was a patient in Oxford, was walking on a meadow by a river with her boyfriend, and she had experienced a trauma that involved being chased by a bull. And what happened is she suddenly got a sense she had to get out of there. That's how she described it. She didn't know why, but she really felt she had to get out of there, and she actually jumped into the river and tried to swim across the river. So an extreme flight reaction, but she didn't know why. Her boyfriend could help us with identifying what might have happened, because I mentioned the trauma involved being chased by a bull. There were some cows grazing very much in the distance that she didn't actually report seeing, but they must have induced this dissociative reaction to her. But what is interesting about this case is that while it is clearly linked to the memory of the trauma, the patient herself didn't spot the link. And this is also typical, and that's why in treatment we often come back to helping the patient, in collaboration with the patient, helping to identify possible triggers, which they find really helpful, because otherwise all these re-experiencing symptoms, very distressing symptoms, seem to come out of the blue, and helping them identify triggers can be really, really very helpful, and we'll have a special intervention for that. I also would like to emphasize that what we call rumination or dwelling about the trauma is also very common in PTSD. People will go in their mind over and over again, why did it happen to me? What if I'd done something differently? Or what if I had not gone out that day? So this kind of just thinking in circles, ruminative thinking, is very common. And initially it wasn't that clearly distinguished from the intrusive memories. But we've done quite a lot of work on that, and we really come to the conclusion that this rumination is also often kind of triggers intrusion and vice versa, but it's a different process. It is, in our model, a way of maintaining the problem. If people dwell on the problem in this kind of circular thinking way, but never really think about the core moments of the trauma that they are concerned about, then that maintains the appraisals and it maintains the memory features. And another interesting observation we made with our patients and also then in research studies is that the moments that come back from a trauma aren't really like you see it in Hollywood movies where you kind of see a whole film of the whole event playing. It's often actually very brief moments, but there seems to be a logic to them in that they often are very brief moments from just before the trauma happened. So the very first thing the very first perceptions people had before the trauma happened. So in a car accident, for instance, they might have intrusions of headlights coming towards them just before they had a head-on crash. Or if they were assaulted, they might see the assailant in their image, might see the assailant standing there with a knife just before they were attacked. Or if it's longer traumas, then it might not be from the very beginning of when the whole event unfolded, but it may be from moments when the event turned for the worse. So for instance, when they really feared for their life, or when they felt something really awful had happened. And that's interesting for therapy because it helps us understand why these moments feel so threatening, because it is just before the very horrible thing happened. So we are experiencing that induces a sense of threat again. Another important observation from the research studies, or from epidemiological studies mainly, is that there is a lot of recovery in PTSD just before, just in the first year of the event, after the event. So these are studies from a very large study in many different countries, and just plotting the recovery from if somebody had PTSD symptoms just after the event and would meet the full criteria for PTSD, how many of them then still had PTSD in years later. And you can see there's a very steep recovery in the first year. So there's an exception in war-related trauma, but for all others there's about 25 to 40% recover. So there is a natural recovery from PTSD symptoms, even if you have a lot of symptoms initially. And for us clinicians, that's obviously interesting to know. So if you get somebody soon after the trauma, it is a kind of a clinical decision to make. Do we need to give them a full treatment now, or should we observe them for a while whether they're actually recovering naturally? And that might be an interesting point for discussion, how later on to see how you do it in your service. But again, from a clinical point of view, it tells us that people have the tendency to recover naturally, and those that need treatment are actually the ones that don't recover on their own. So we are interested in factors that prevent people from recovering, the maintaining factors, what makes people get stuck in their recovery. And to answer this question, David Clark and I and our group also thought about another component of the presentation, and that is that many of the symptoms of PTSD are symptoms of anxiety, if you think of hypervigilance, if you think about avoidance or startle responses. And from a cognitive point of view, we actually conceive anxiety as an emotion that people have when they anticipate a future threat. But in PTSD, the trauma is something in the past. So how do we explain this? And the idea we suggested in the 2000 paper that you might have seen is that actually people with PTSD process the trauma in a way that leads them to perceive a serious current threat. And that is the core hypothesis that actually is very useful also for our supervision in cases. We often find that people with PTSD have quite a lot of problems. Some of them might be secondary to the trauma, some of them might have already preceded the trauma. But if we really want to help them with the PTSD, we found it is really helpful to focus, when you feel stuck in therapy, to come back to this basic question: what is actually leading to the sense of current threat at that moment? And I should say that this threat can be either external, they are afraid another trauma might happen, they might be attacked again or something, but actually the most common one and the most important one, I think, in PTSD is a threat about what the trauma has shown about themselves. So their sense of self is very much threatened by the trauma. So this already leads me to this, to what are the sources of the current threat. First of all, we propose that people with PTSD for people with PTSD, the trauma has very highly idiosyncratic meanings that go beyond what other people would find horrible about the event. So it's not about that being threatened and your life is in danger is not a horrible thing. It is about what goes beyond that we are interested in here. And it can be about the trauma itself or about the aftermath of the trauma. That's another important aspect. And secondly, the idea is that there are specific characteristics of trauma memories that we can observe in our research and then can change in treatment. And this is summarized here, but I'll explain it a bit later in more detail. So two sources of current threat, the appraisals and the memory features. And then why don't people get better? They do things to actually make this threat smaller, to control the threat they perceive. And people are very, again, it's very idiosyncratic. PTSD presentations are very varied, but they both, these strategies have in common that they maintain the sense of current threat, and they also maintain the disorder by actually preventing a change in the memory and the appraisals. And here's a whole list of them. Thought suppression is one common one. Rumination I already mentioned. Hypervigilance, safety behaviors, and very common also substance abuse. I'm sure you see that in your patients. In cannabis, very common, or alcohol, but we also, and it's useful to ask for all substances. Like, for instance, I remember we had a patient who drank 20 cups of coffee a day, plus Coca-Cola and so on. So it's like using caffeine because he thought that was controlling his experiencing symptoms. So really ask the whole range of substances. And this is a graphic presentation that, in our mind, helps people sort the information that we get from our patients to understand their presentation. So the idea is that people with PTSD perceive a current threat that's accompanied by these intrusive memories or experiencing symptoms, strong emotions. And I should say here, it's not only anxiety, but a whole range of emotion. Guilt, shame, anger are very common in PTSD. And the sources that we talked about briefly, but we'll expand on, are the trauma memories, are in not a good shape, we could say simply. That means that if triggers are present, re-experiencing symptoms are triggered easily. People with PTSD have these appraisals that go beyond what everybody finds horrific in the situation, and they use several behaviors and cognitive strategies to control the threat that maintains the problem. Just a little bit of a briefer look at the appraisals now. I already mentioned it goes beyond what everybody finds horrific. And as therapists, we have to be quite careful that we don't jump into the cognitive restructuring right away, because I think people really deserve our full empathy for going through a horrible experience that nobody should go through, and we really want to make that clear to them. But we as therapists want to look out for any distortions in what people perceive happened in the trauma and what it means, and that's something we can work about. And I already mentioned it's commonly about the self. So I'm a bad person is a common one. I'm a bad father. I'm a bad mother. But also is external threat. Will be assaulted again. Often also generalized to close people that are close to you, like people that we've seen, for instance, wouldn't let their children go to school anymore because they were afraid the children would be attacked on the way to school or in school. So it can be very generalized. And I can only really say it's highly idiosyncratic, so it needs unpacking when we talk to patients. What are the individual appraisals? And that actually is interesting. It also applies to people who have been in the same trauma. So we both worked with the survivors of the London bombings and the Omagh bombings. And people, for instance, in the same carriage in the London bombings, all had different appraisals of what subjectively was the worst thing for them. And here are some questions about how you can elicit these, like what was the worst about this? If that had happened, what would that mean to you? What would it say about you as a person? A few more words about the features of trauma memories that we have observed that give us hints about how to treat PTSD. I talked about the memories being disjointed. I want to explain that a bit more now. So the idea is that trauma happens often very suddenly. It's overwhelming. People have never experienced something like that before. And this leads to the memory being quite disjointed. That means the different parts of the memory are not joined up fully together. And we call it a lack of updating that happens. So in a typical example, I mentioned threat to life is very common in trauma. People will have had a moment when they felt their life was in danger, and the meanings for that could be, I will never see my children again, my children will grow up sad all the time, they miss me, and nobody's going to look after them. And interestingly, when they have the intrusive memories, or in therapy remember those particular moments in the trauma when they felt they were going to die, will actually then have the same emotions we had at the time. So they feel all the sadness about their children having to grow up without them, although they have survived and they live with their children, but it's not, although they know it, so it's not linked up in memory to this particular moment in time. And a lot what we do in the treatment of PTSD is actually find what we call the updating information. So what is the information we need to bring into this moment that's represented in the re-experiencing symptoms and link it up so that it's like emotionally sinks in, I didn't die and I'm still living with my children. But there's other things we can observe in the memories that can be helpful to discover. So there's often a confusion about the order of events in a trauma that can influence the appraisals. So for instance, we treated somebody who had worked, who was a paramedic, who had attended to a family with his colleague, and there was a man who the family suspected had a serious illness and needed to be taken to hospital, but it turned out it wasn't the case. He didn't need to go to hospital, but the family didn't quite believe that. There was an argument in the course of that event, of that visit, and it ended up with our patient and his colleague being beaten up by the family. This patient developed really very severe avoidance behavior. He couldn't go to work anymore, he couldn't go shopping in his local supermarket, because what he had taken from the trauma is people from this particular ethnic group that this family was from are dangerous and they are going to attack me again. But when we went through the trauma in detail in therapy, what emerged was that he had tried to leave because they needed to get to the next call, they were needed elsewhere. And so he and his colleagues had tried to get back into the ambulance, and he was trying to close the door, and the family tried to keep the door open so that they couldn't drive away. And then our patient had actually punched the person in the face, and then they were attacked. And as you can see, that changes the meaning quite profoundly. It wasn't the family had started the physical violence, but it was our patient. And that was the turning point for him when he discovered that the order was the other way around, because they seemed much less threatening. So, and then he was willing to engage in resuming his life again, because he could restructure that part of his appraisal. These people are dangerous. Important details may be missing as well. We've seen it a lot in our patients as well, that, for instance, in rape survivors, that they are very ashamed about particular moments of the rape and feel they should have fought back more, they shouldn't have done what the perpetrator told them. And when they actually go through the event from the beginning to the end, they remember that actually the perpetrator threatened he would kill them if they didn't do what he said. And that information can be then very crucial to bring into the moment when they felt ashamed. They did it for a good reason. They wanted to stay alive, of course. And another interesting point is that false information can be coded as true during the trauma. And even if you find out later it was false, it still stays traumatic. So people who are threatened with toy guns, for instance, they will, at that moment, of course, believe it's a real gun and I'm going to be shot, I'm going to die. And if they later find out, oh, it was only like a replica gun or toy gun, that doesn't help them with the re-experiencing symptoms. So again, that's the idea that we have to bring in that information into that moment when they actually had this thought, I'm going to die. So we need to access the relevant moments in memory and then update the meanings in the treatment of PTSD. And another clinically interesting observations in this respect is that the moments that are re-experienced may sometimes be missing from the account of the trauma. So if you get a patient to tell you what the trauma was like, how it unfolded, even if the story sounds quite coherent, there may be moments missing that you only find when you ask them about what their re-experiencing symptoms are. So that's why we always ask people about the content of their re-experiencing symptoms and then see whether we can match it up in the course of event. So that's diagnostically important. So how does the memory, why does the memory appear to be happening in the here and now? I think I've already went ahead of myself and I'd already talked to you about the disjointedness of trauma memories. They are not really fully linked in with the rest of the memory of the trauma itself. And I think that's something we learned over time. I think if you read older literature on PTSD, there's a talk about the whole memory being fragmented. We've learned with time that it is actually mainly those moments that are around the intrusions that we are interested in for the experiencing symptoms. So it's the worst moment. The patients will usually describe them as their worst moments, or we need to treat them because they have re-experiencing symptoms about them. So those are two ways to find them. And the way autobiographical memory works would then mean that if it's not linked up properly, it's easier to trigger by sensory cues, and also you retrieve it without the context. So you retrieve it without actually knowing I survived and I'm still living with my children. So that's why we use the updating memory procedures that I'll show you in videos and also describe to you today. The triggers of re-experiencing symptoms are also really interesting. So when you ask patients with PTSD to describe what triggers their intrusive memories, they are all often not very sure. They will give you a few things that have a meaningful connection. So for instance, they might say if they were stabbed, they may say, oh, I don't watch TV anymore, I never read the news because there's so many stabbings in London and I get so many reminders then. So that would be like a meaningful reminder. But actually, most of the triggers we discover in therapy with the patients don't have this meaningful association. They are like just temporal association of something that happened to be around at the time. And it's often a sensory cue. So, and the interesting thing about that is that it's often only one sensory similarity in a whole situation that's completely different. So again, an example from one of our patients who was traumatized in hospital and couldn't really name triggers. So in the course of therapy, the therapist and the patient visited a local hospital that wasn't the same as where the trauma happened, but just to get some ideas about what cues are there in a hospital that could trigger the memory. So they thought about something like smells in hospital or maybe seeing somebody who looked like the surgeon or something like that. But it turned out the patient had a massive flashback just going into the reception area into a hospital. And when she had calmed down a bit and oriented herself again, the therapist and the patient could identify that it was a vase in the reception area with flowers in. So you would think that's a nice thing, shouldn't really be threatening at all. But it turned out that the vase had the same color as the surgeon's coat. And this kind of particular greenish, light greenish color that the surgeons had at the time at least, was a trigger for her. And we could then, once we found this, we could then replicate it with other objects that didn't have anything to do with hospitals and had the same color that those would bring on the flashbacks. So we are looking for really sensory cues, and it can include also body position, like somebody who was stabbed while they are lying in bed, then we found out that it was only when he was lying on one side, like the same side that one was asleep in when he was stabbed, and not when he was lying on the other side. And a lot of the patients who have a very severe sleep problems, we find there might be something similarity in the trauma. Often people get to lie and they're injured or something, they're lying, and that can also contribute to sleep disturbances then. So we have done experiments and so on about finding out what learning mechanisms play a role. I think here it's sufficient to say that what seems to happen, some very basic learning mechanisms such as perceptual priming and associative learning, which you also have heard about, like Pavlovian conditioning, taking place. And they lead to a very poor discrimination between the triggers in the current environment and those that were around in the trauma. And that's why we're really working on discriminating those triggers. So we have a special technique for that. So this is the thinking behind the treatment, and we'll come back to that. I wanted to really share with you that how important the phenomenology of and the kind of very different presentations that people with PTSD have been for us in finding out what are the similarities where we can intervene. And just a brief overview, we won't explain all of these, but on this slide, it just tells you what we think are the core interventions that we need to treat PTSD effectively. First of all, again, a reminder that we really focus on the sense of current threat, which stems from the trauma appraisals and the memory features. So that's why we worked in a trauma-focused way. And we found that in our own work more effective than just focusing on the appraisals like with cognitive therapy methods. So we think that you gain more by focusing on the trauma. And we use cognitive therapy techniques and memory work to change people's cognition so that then we can change their emotions. And the interventions are listed here. Case formulation, that's individually tailored. We're going through all of those. Reclaiming your life assignments, guided discovery and behavioral experiments to change problematic appraisals and the behaviors that people have and that maintain the problem. The updating memory procedure, identification and discrimination of triggers. We also suggest doing a site visit. I know that's not the most popular suggestion because it's a bit of extra effort, but we think it really pays off, and I'll show you why. And we're doing a blueprint at the end. The Reclaiming Your Life is an interesting one because we think this is something that is quite important to have as a balance to all the trauma-focused work that we're doing. It's basically suggesting that people re-engage in activity that they did before the trauma that were important and meaningful and enjoyable to them. And we do that in a bit of Reclaiming Your Life is part of every treatment session. I'll only mention it in the first session, but I just want you to remember that's something that goes all the way through treatment, that we have some time of a session dedicated to really getting people back on track with reclaiming their life or rebuilding a life for themselves. So So that's not trauma focused, but very important too. And then the other techniques that we're using really all center on this, the three components I mentioned: the updating memories, the working on the appraisals, and modifying the behaviors. And they often go hand in hand. It's not really like in treatment you can separate them out, like first I work on the memory and then I work on the appraisals. I'm hoping to show that it's really very integrated. For the purpose of a workshop, obviously we have to do them one after the other, but it's all linked up together in a meaningful way. And it also means, I think the good thing about it, it's not a kind of session by session treatment, because you tailor to the patient. And let's say you don't make much progress with modifying appraisals, then it gives you ideas where else you could kind of get into the system, by maybe by focusing on rumination for a while, and then like loosening beliefs that way. Or you do some more memory work, and that helps finding another part of the memory that explains these appraisals that we still have to work on, that somehow the patient hasn't mentioned before. Often with shame, that's a common thing, that people might not want to, in the very first session, tell you everything that they are ashamed about. And there may be something else that comes out a bit later in treatment. So that's kind of a picture, I think, that summarizes what happens in treatment. And I mentioned that it's individualized, and the course of therapy has common elements, but for different main appraisals and the emotions that go with them, we tend to use slightly different techniques that work best with those appraisals. So I'll show you examples of people with overgeneralized sense of risk, so people who are afraid that another trauma is going to happen. And for those, the crucial intervention would be to do behavioral experiments, and also while they're doing the behavioral experiments, make sure that they drop their safety behaviors and hypervigilance. That's maybe more similar to other anxiety disorders, where we also work a lot on dropping the safety behaviors. But now if we come to somebody who has various parts of the memory that they are very ashamed about, then the idea would be to widen their perspectives. People are ashamed, often very much focusing on how they felt at the time and how embarrassing it would be if other people knew about it. So for them, it is like really looking at the belief that other people will judge them badly. And one technique that we find terribly helpful there is doing surveys where we decide on questions with the patient that they would like to ask other people, but wouldn't really feel up to asking people they know. So the therapist usually sends them out, and the people are always surprised how little other people judge them and how much more understanding they are than they feared. And that then gets fed back into the trauma memory. For people who are very preoccupied with injustice, that the trauma happened to them, not to the perpetrator maybe have got away, or the person who caused an accident got off light injuries, and they have very severe injuries, maybe still suffering from them. For them, it is really very important to feel understood and to be heard. So the empathy of the therapist is extremely important here, important for PTSD in general, but for people who are very angry, especially because they have the experience that other people get tired of hearing about how angry they are and don't want to listen anymore. Or, most importantly, often that the person who did the harm to them never really had heard about that. And there's various interventions that you will find in your handout, but the ones that I want to mention is like we often end up doing an anger letter, where they actually write down a letter to the perpetrator or the person who caused the accident, where they express how much they suffered through the other person's doing. And this letter is usually not sent, but just writing it down and really putting it on paper, really people find that really helpful. Occasionally we send it like, and our like sometimes the therapist sends it on behalf of the patient, for instance, if it's like a hospital, something going wrong in hospital or something. And then our doing that as kind of medical kind of profession kind of validates their feelings and their irritation with what happened to them. So that can be helpful. And then also a cost-benefit analysis, like who is actually served by the anger. Is the injustice being undone by keeping angry is very important. And if people blame themselves for what they did or didn't do in the event, or that they blame themselves for the event happening at all, we look at again widening their perspectives of what are the other factors that contributed, and then they usually actually there's quite a lot of other things that contributed, and then we summarize that information in the pie chart. So in the extreme case, if somebody feels, oh, they shouldn't have left the house and the trauma wouldn't have happened, then we could say, well, actually the main person who is responsible is the perpetrator. He actually attacked you, and your contribution actually then ends up very small in the end. If the patient experienced mental defeat during the trauma, that's a perceived sense of all autonomy, being an object, or even wishing to be dead, giving up completely, or feels immensely humiliated by the trauma, we would focus in treatment on the perpetrator being wrong and the perpetrator intending to induce these feelings in the patient. It wasn't the patient who was inferior in some way, and address their self-criticism. This may include doing some surveys as well. If the trauma is a traumatic loss of a loved one, we would focus a lot on imagery. This, for instance, would be about imagery about the deceased being at peace, conversations with the deceased about things they regret about their relationship or about the way they died, and also about how they can carry the essence of the deceased with them, again often doing imagery such as images about the loved one really representing joy in their life, which can be an image of sunshine, for instance. And some of this work can be done to prepare for the memory work. For instance, in mental defeat, we know that repeated exposures of the moments when they felt this defeat are not helpful. So doing the cognitive preparation can help us making the memory work be convincing and stick in memory then, and reduce these feelings of defeat and humiliation. A few other points about what doesn't happen in cognitive therapy. I don't know what main treatment modality you're currently using. Prolonged exposure is a very successful treatment program as well, and those of you who are trained in that, there's a lot of overlap, but we don't really repeat the exposures as much as it would be done in prolonged exposure, and we don't really have the idea that we need habituation to be the mechanism of change. We use the updating instead and the stimulus discrimination. So that's why we also don't do exposure hierarchies as such. We also don't rate anxiety. We'll rate distress, but we are actually mainly interested in belief ratings and nowness ratings in our therapy. And then now if we're looking at cognitive therapy methods, we usually don't do thought records. They are useful with depression, but in PTSD, it's really about the appraisals of the trauma that we're working on. And we also don't do like rehearsal of rational responses or positive thinking. So just to give you a flavor of what's not in that, because there's a lot of different procedures that I'm talking about. And the next two slides are just about if we're looking at a patient who has a few traumas, let's say 1 or 2 traumas, what would the treatment usually look like week to week? I said it's very individualized, so there's always exceptions, and I will tell you some of those along the lines. But usually we would try to go into the work with the trauma memory quite quickly. So we would have a diagnostic assessment where we look at whether somebody actually has PTSD and whether that's one of the main problems. And then we have what we call the first therapy session. Still has an assessment function, but more looking at the cognitive aspects of the presentation and really looking at these three factors: appraisals, memory, and behaviors and cognitive strategies, but also really to build up a relationship and to instill hope. And we would start we would normalize symptoms, do an individualized model of the factors that maintain PTSD. We start reclaiming your life right away, and we also have a first go at getting a kind of an account from the patient of what happened in the trauma and what the worst moments were. Sometimes we don't get it all, so don't feel totally frustrated if you don't get it all done in one session. But that's our aim, to do as much as we can, and we then expand on those things we haven't covered. So that in the second session we could then start with the memory work. And what I should say, what we have changed over time is we used to do a few more sessions of just kind of working on the trauma memory without putting updates in. But we now actually will do it as soon as session 2 and sometimes even in session 1. So if you find something that you can update right away, go for it. There may be other things that need longer, but it's amazingly motivating for the patient if they actually see they have already done some work with the memory that they found helpful. And then we would work on one theme at a time. So continue with the updating, and then we would usually start with the stimulus discrimination of triggers around session 3 or 4, and the site visit would be later around 8 or 9. However, I would like to emphasize that this is not a treatment with a session-by-session protocol. The order of the intervention is not fixed and is designed to really fit the individual case formulation. And there are common variations in the order of interventions. For instance, for patients who dissociate, we would usually do some trigger discrimination work first before we then start writing narratives or go into imaginary living, because this will help patients stay in the present while they work on their memories. For some of the emotions and cognitive themes that people that we identify in our patients, we will prepare the memory work with some work on widening their perspective on what happened in the trauma. People who are very ashamed about moments of the trauma, for example, or who experienced a mental defeat where they had a perceived loss of all autonomy during the trauma, are really often very much focused on their own feelings at the time and what they thought at the time, without really taking in the contribution of other people to the trauma. And here it can be helpful widening their perspective, for instance, to really saying that it was the perpetrator's intention to humiliate them so much, and it was their doing. It wasn't something bad about themselves that was happening there. And then they can engage more productively in the memory work. And if somebody lost a loved one in the trauma, again, we wouldn't rush into the reliving in the first few sessions as we saw in the other slides, but we would really give them the chance to talk about their relationship and the loss they perceive, to really show that we are with them and really supporting them in this very difficult time. Importantly, if we do these variations, it's really always with the perceived current threat that the patient is experiencing in mind. So it's not a detour in the sense of working on other topics. It's really very focused still on really targeting their perceived current threat and the appraisals and memory processes that contribute to them. The treatment works. It has been recognized in the NICE guidelines that cognitive therapy for PTSD is one of the effective trauma-focused treatments. And overall, we get an effect size of about 2.5. I don't know whether that means anything to you. It basically means that it's a unit in terms of standard deviation of symptoms. And the improvement is really very large. And that means if somebody has moderate PTSD to start with, you can expect them to go into the symptom-free or minimal symptom range. If somebody starts out with very severe PTSD, some of them also are symptom-free afterwards, but you would usually expect, with an effect size of 2.5, to have some like minimal or moderate symptoms left. So, but in any case, a very big change. A few more general remarks about the treatment. First of all, the treatment duration, I should say, is not fixed in clinical practice. In trials, obviously, we have to say, people can have up to 12 weekly sessions. That's what we usually use for 1 to 2 traumas. We can also, if it's related traumas, we can also cope with more in that time. But importantly, it is to say that we always do, if we're working on trauma memories, we always allow 90 minutes. And is that possible in your service to do that? I think that's really one of the things that I think all CBT programs for PTSD recommend. Because let's say you're dealing with somebody who dissociates, you don't want to send them home if they're in a dissociated state. And you never know until you do it, you never fully do. You have warning signs for that. So 90 minutes, later sessions can usually be shorter, 60 minutes or so, but really allow enough time for the memory work. We also have successfully used the treatment in an intensive format where we deliver the treatment, basically the same interventions, but we deliver them daily over up to 7 working days. That also works very well and can be good for people who have a job that doesn't really allow them to take a week off every week, some time off every week. So they take holiday and then we come for the treatment and so on. So that works in our experience as well. We also, and that I don't know whether that might become relevant for your service, we also have developed self-study modules where we cover elements of the treatment that we thought the patients could handle on their own, like rationales that you give to every patient and like first explorations of why they feel guilty. And we've done a trial where we used the self-study modules and then half the number of sessions with the therapist, so 6 sessions with the therapist, and the rest was done in the self-study modules. Again, that worked as well as the 12 weeks treatment. So there are some possibilities to deliver the treatment more efficiently, and we're actually currently doing internet-delivered treatment where we can reduce it even further. But we don't have the outcomes yet. It looks promising, but we can't tell you the results. And what helps us to really move patients through the program in quite a pace to deal with the memories. First of all, like with other anxieties, also we record each session, and the patient has a copy of the recording and ideally listens to it at home, and that often consolidates things they worked on. As you know, they have poor concentration, so being able to listen to it again can be helpful. Again, there are exceptions. If people dissociate and you talk a lot about trauma memory, you wouldn't necessarily give it to them early on. But overall, people report that it's helpful to have the recordings. We have the weekly questionnaires, I mentioned that already, and just a reminder, in addition to the questionnaires in the session, we also really keep a close eye on how well our intervention actually has worked with the particular appraisals that people had. So how much do they believe that it was their fault? We track it with percentage ratings very, very often. And also the nowness of memories is something that we are really interested in, because that shows us we have really done some work that has been helpful. So that's my very quick overview of what we emphasize in treatment. So I'd just like to give you a chance to ask questions or comment on what I've said so far. Does it coincide with your observations in your patients? Yes.
When you said that you might send a letter in to something like a hospital if you have a problem in a hospital, would you do that in a kind of quite a formal way? Would you send it as a therapist and you say you was...
Yes, yeah. In a few cases where we've done it, it was the therapist sending it on our like normal kind of stationery, but obviously formulated in a slightly different version of the anger letter. So it's more formulating it more. Well, your patient, this happened to the patient, and they were very distressed by it, and we'd like you to know so that you can look into your procedures. So it was politely worded. It wasn't the same that the patient would write everything they are angry about. But we found that our patients found that we appreciated that a lot, because they often have the experience they have tried to complain, but then that wasn't taken further, and they never heard about what the reaction was.
I'm seeing a patient at the moment.
Oh yeah.
And it's about a death in the hospital, a baby death in the
hospital. Oh
yes,
yeah.
And it was a horrendous multiple negligence, really.
Oh dear.
And what's happened is that the management have talked to them, but
no
one's ever contacted the actual people who are on the ground not doing what they should have been doing. So it's quite a difficult situation.
Yeah. Yeah, I think, I mean, our power to change things is obviously limited, but I think it's just the fact that we are also like in the helping professions, and we agree with the patient that the procedures should be looked into. That can be a big important message. Yeah, so it might be worth trying that. Yeah. Thank you. Okay. So now I think we're trying to do a coffee break at about 10:30. Can you still, is that still okay? Good. So I'm now going to go through the treatment procedures, and I'll start with things that would happen in the first session, as I described. So just one thing to remember, and you probably have had similar experiences, we really have to go out of the way for the patients, to make sure the patients feel safe in the therapy environment and also with us. And knowing about the subtle sensory cues that can trigger re-experiencing is quite important in that context. So I'll just give you one example. We had a kind of prison officer in treatment, and you actually have those kinds of blinds here. So we had blinds like you have in this room, and it was in the summer. The therapist had this kind of what I'm blocking on the blinds, kind of so that the sun didn't shine into the room so much. And the patient just couldn't relax with the therapist. And several sessions went by until they spotted that actually the distance of the blinds was actually the same as like in the prison cell, like in the little window where they have the bars. And that made him very, very uncomfortable. And once they sorted that out, and then they could actually proceed with the treatment. So if a patient doesn't relax in the office and or at least so much that they can engage with you, then it could be something about the setting that bothers them. And the same as therapists, we need to be obviously safe people for them. They need to be able to trust us. And that can take a bit of time until they really know us a bit better. But what can we do to help with that? We can really be very empathetic and also, I think, signal that we know about PTSD and we understand how difficult it is to talk about the problems, and really understand that we understand how much they went through, and also that we are on their side, especially if somebody is very angry, that we really want to be very, very sure. And the other thing is that we are comfortable with the detail that we're eliciting and the trauma, that we can cope with that. So otherwise the patient will avoid giving us the detail. What other things would you like to know about patients before we start? I think there's a lot of things going on in people's life often, but and there may be a comorbidity, prior trauma, physical consequences like surgeries coming up in a few months' time and so on. But I think the real question that we are asking here that's really important is PTSD the main problem that people need to work on at this moment? And I think there's often a tendency, oh, there is a trauma, it must be PTSD, and therefore PTSD treatment has to be given. And it might just be that, and it might be true that the patient needs treatment for the PTSD, but at that moment of time, other things may have priority. They may have very severe depression, so that they can't really leave their house at all because of the depression, or don't get out of bed. They might have family problems ongoing that really absorb all their energy at the moment and need to be sorted first. So there may be other things that are more important for them at that very point in time. And I think it's important to assess that properly, because otherwise you're bound to find that the other things will interfere with the PTSD treatment. And risk assessments are important. People may have had a history of suicide attempts, or they may be self-harming. And it's a matter of, it doesn't mean we can't treat these people, but we just have to see whether there's an acute risk. And if that's not the case, then I think it's safe to go ahead with PTSD treatment. But if there are already plans for suicide and so on, obviously we have to deal with those first. And looking at the patient's goals is important. Do they line up with what we think is important? Does it contain things like, I don't want to have all these re-experiencing symptoms, I want to sleep better, I want to be able to work again. All those things we can help them with. And if they say things like, I just want to forget the trauma and I want you to hypnotize me so that I don't have memories anymore, those kinds of things, then we obviously have to inform them that this is not possible, that's not what we can offer instead. So that would be important. And we would look at the questionnaires, but also in our initial conversation with the patient, really look at the cognitive themes by questions like, what was the worst about it? What's the content of the intrusive memories? Do they have a misinterpretation of symptoms? Do they believe their PTSD symptoms mean that they are going crazy or have a brain tumor or something like that? So spotting those kinds of appraisals early is really important. How confused is the account that people give of the trauma? And also look early on at the maintaining behaviors and cognitive strategies from the very first session onwards. Again, that is something to be added to later on, but usually we find that most people will engage in thought suppression, for instance, and so asking them about what do you do if memories of a trauma pop into your mind. People will say, oh, I really try to distract myself, or I have to keep busy all day. Like people will clean their house all day long so that they keep busy to just not have the memories popping into their mind. Things like that. The rumination is good to ask about, do you dwell on the trauma? Safety behaviors, if you can elicit them right on numbing. And the thought suppression I mentioned, and we'll come back to that in a video in a moment. So I mentioned that we want to develop an individualized version of the model that we're working with, because that will guide us and the patients through treatment. And we need to also kind of reassure the patient in a way that their symptoms are something we know about. It's not that they are going crazy. It's something that's well understood. So we normalize their responses. And also we want to bring across, I think that's a bit of a danger with therapy, that we as therapists then show them things that they then understand as meaning, oh, that was really silly of me that I behaved this way, I should have done it differently. So we want to really bring across that we as therapists understand the way they try to deal with their symptoms, and this is really very common, very understandable, but then plant the idea that actually what they've done so far may not be the best way of overcoming the PTSD, and that it might actually contribute to maintaining the PTSD. So, and then plant the idea that what we'll do in treatment together, and we'll help them on the way, is that we reverse some of the things that we've done so far, so that they can find out actually that what the appraisals were that don't match reality so well. So if they give up their safety behaviors, they can test whether actually it's very likely that they be attacked again. And the core of the normalizing again goes back to then the memory, dealing with the memories and explaining the patient's reactions as a sign that the memory has not laid down properly in their in the autobiographical memory. And we try to individualize that as much as we can to already what we know about the patient's own appraisals. So just here an example from a lady who was run over by a car when she was trying to cross the road. And there were two main symptoms that were linked to very idiosyncratic appraisals. First of all, she had felt quite depersonalized during the trauma, so a sign of dissociation. And this feeling kept coming back. And for her, it meant she had already turned into a ghost. She had actually died in the trauma, and she wasn't really alive anymore. She was now actually like walking around like a zombie or like a ghost. And the other one was that she was actually a very brave lady who had you knew about the basic idea of exposure. So she knew that, like, if you fall off the whole horse, you have to go back on the horse, and that will overcome your anxiety. Just so that in her case, the dissociation got in the way, because whenever she was trying to cross the road, she would get a massive flashback, and in her case, that meant she actually froze. So she would actually try to cross the road and then freeze in the middle of the road. And that was very frightening, of course, for her, and also potentially dangerous. And for her, that meant only a crazy person would do it. Who would, like, you were trying to cross the road, why would you then stand in the middle of the road and not move? So we wanted to do the normalization and the explanation that this is due to the trauma memory to fit with her appraisals. And so we tailored that general explanation that we give to her symptoms. And the idea in general is that the trauma may happen so fast, it's so overwhelming, that you can't really process everything at the time. And so that means the memory is kind of a jumbled up memory. It just gets put together too quickly. It's not like any other autobiographical memories. And the important thing is that it will bring back exactly what you felt and what you behaved in the trauma. And in her case, it was this feeling of depersonalization. It was like she had this kind of going out of her body experience. And that is very common. It's like a reaction that animals also have when they freeze in front of a predator. So they would, so her freezing in the road didn't mean she was going crazy. It was just like replaying that was when it was in the memory, because she also then couldn't move, of course, when she was knocked down. And it is really like a time travel back to the moment of the trauma. And it doesn't mean that she's a ghost now. She didn't die. It just feels like this because she has this depersonalization. I have on this slide a longer, like, written out version of the main points from the individualized formulation that you can then adapt to your own patient's symptoms and also interpretations that you already elicited to that point. I should say that the graphic display that you have in the paper and also that I showed you, we tend to not use with the patient. We use it more for the therapist as a kind of conceptualization. So we often use like just a sheet and then write down everything we found out about the memories and everything we found out of the appraisals and all the behaviors they use for you as a therapist to keep track of what's going on. But for the patient, if we do graphic presentations, we usually do like mini vicious circle models. So like between feeling that another assault is going to happen, then doing safety behaviors, meaning that you can't find it out, and then that confirms your belief. Those kinds of smaller vicious circles we would share with them in graphic form, but not so much the general overall big model with all the different components. We found that was a little bit too much. So we do it more like in simple words, like with main ideas. And here's an example. Some therapists find it useful to use the graphic presentation of the cognitive model to keep a track of the individual case formulation through the course of treatment. And here you see an example from a paper by Hannah Murray that you find on the COVID part of our website, on an example of a patient who was treated in intensive care. And you can see that there's quite a lot of detail that contributed to the disjointed trauma memories on the left-hand side. For instance, the beeping and the PPE uniform, the strong physical sensations they had, and the delirium they were experiencing. And then that meant that sounds that were similar to the sounds in ICU, smells of disinfectants, for instance, the color blue like the PPE uniform, would trigger very strong intrusive memories. And again, the appraisals that the patient had were linked to the trauma memory. For instance, they interpret what was happening to them as the staff are trying to kill or torture me. And then finally, the appraisals and memory processes were maintained by dysfunctional cognitive strategies and behavior. So they avoided any health professionals, ruminated a lot about what happened, and were very much withdrawn from other people, so they also didn't hear about what other people knew about what happened to them. You will appreciate that this is a quite complex formulation, and we, in our experience, too much to share in one go with the patient. So we tend to draw out smaller maintenance cycles that we share with the patient that we can then work on together. So for instance, in this example, the memory of being alone in hospital and feeling abandoned there led to the patient to believe that nobody cared about them. And as a consequence, they avoided their friends and even didn't return their phone calls when they tried to get in touch, which then meant they had fewer invitations and calls, which then reinforced the belief nobody cares about me. So they were stuck in this vicious cycle that we then tried to break in therapy. Another general point that were the rationale or the explanation that the symptoms are normal, sign of normal reactions to an abnormal situation comes in, is that we actually shouldn't forget the importance of information. So it's called cognitive therapy, but it doesn't mean that for every appraisal that the patient has, we need to have a sophisticated cognitive restructuring. Rather, sometimes it is more efficient to actually get the right information from the right people. So just explaining to patients how certain procedures work. For instance, it's quite common that people don't understand the triage system in hospitals, and they felt nobody cared about them, and they were left there waiting for a long time, and so on. And just understanding that actually the brief assessment at told the doctors that it was an immediate risk to their lives, and that's why they had to wait so long, can be helpful. Also, sometimes people misinterpret things that happened afterwards that can be easily cleared up. So we had, for instance, one patient who was really, really very careful in not putting any strain on his body after the event. And when we asked him about that, he said, well, his body was permanently damaged in the trauma, and he had to be really careful. And he also had panic attacks as well. And what turned out was that his evidence for this interpretation, my body is permanent damage, was the color of his urine in hospital. And I think it was some kind of bright orange or something. So he had interpreted as, well, there's internal bleeding. So the organs must all be damaged because I'm basically, my urine is just bloody. And we found out by talking to colleagues, we as psychologists didn't know that either, but a drug, some kind of antibiotic drug that was commonly prescribed actually caused that color. So knowing that, then feeding that back to the patient was enough to deal with that appraisal. So just look out for and ask experts. I just want to encourage you to ask around. If you don't know the answer, that there will be somebody who know about it. Some things you can find out over the internet, but we found that other people are usually very helpful if you explain you need to know about this to help a patient, and they will give her time. So for instance, we have talked to electrical engineers for people who had been electrocuted, or like people who, you must have had that as well, when people are in car accidents they are trapped in the car, they often think the car will explode, and that they are very afraid of that. So we talked to people who know about cars, and they reassured us that the petrol is very far from the hot parts, the engine, and this is very unlikely to happen, even though it's shown in all the Hollywood movies when there's a car chase ending in some explosion or other. But in real life, that actually is super rare, and very, very unusual conditions would be necessary to make that happen. So those kinds of just information about what was happened can be extremely helpful. And in some cases, we've also then brought in the person who is the expert into the session. So for instance, I remember in one case where it was really important. It was quite a protracted trauma, and the person ended up in hospital for quite a long time and was really close to dying. And what happened was that she was already very confused when she was in hospital. And she understood that she had been tortured in hospital. So what people had done, so what in her perception, she was like in this place, and people were doing all kinds of things that were painful and so on to her, and she didn't understand. So her only explanation was, I'm being tortured. And in her case, it didn't quite work with the therapist just conveying like what we know about procedure. So it was necessary to, we had an accident emergency nurse, luckily, that we could ask to come in for an hour, talk with the patient, and really take through her given her medical problem, what the likely procedures would have been that would have been done, and why they were done, and why they didn't actually have time to talk to her about it, because they were saving her life, so they couldn't really do long explanations before, and they had to just do it immediately, otherwise she would have died. And that was extremely helpful. So just encourage you to think of that. If you get stuck with like trying to restructure what was happening, there might be somebody else who has more detailed information that might be helpful. Okay, so now let's go to one of the first experiential exercises that we do with our patient, and that's the thought suppression experiment. You may have used it already with people with OCD and so on. I'll give you an example here for how to do it in PTSD. The idea is the same. If we try very hard to suppress a thought or an image, it's more likely to pop in our mind, and that's a maintaining factor in PTSD as well. People will really try very hard not to have these memories, so they push them out of their mind really quite forcefully. And we do it without a lot of introduction, so that it's really like an experiential exercise, and then we do what it shows us discussion afterwards.
So I'd like to try a little experiment. So bear with me if this sounds a little bit strange, but for the next minute or so, I want you to think about anything you like, but don't think about a bright green rabbit sitting on my head, eating my hair. Okay? So anything you like, but don't think about that rabbit. All right? So let's try it now and try not to think about it. Okay. How did you find that?
I kept thinking about the rabbit.
Did you?
Yeah.
Even though you were trying not to?
Yeah, I was trying to push it away, but it kept coming back into my mind.
Okay. So even though you were trying to push it away, it was coming back?
Yeah, I guess once you've got something in your head, it's really hard to stop thinking about it.
Yeah. And what do you make of that in terms of the memories that you have of the accident?
Well, I guess pushing them away doesn't mean they go away. The more I try to push them out of my mind, the more they actually come back.
Right, yeah. And that's really how our minds work. Sometimes when we try really hard to push something away, it actually comes back even more. So it sounds like you're caught in a bit of a vicious cycle where the memories come, you push them away, and then they come back even more.
So this brief experiential exercise then also leads to a homework assignment that we can give in the first session, and that patients can, now that they understand that actually suppressing the memories is not, actually doesn't have the desired effect, actually might backfire. We encourage them to experiment in the following week, and you may want to decide certain days when they experiment to do things differently from what they usually do. With actually letting the intrusive memories come and go, and we use again a metaphor here that of a train going through a station. So if they kind of picture themselves on a platform, and one of these trains that go through the station comes by, it wouldn't really make sense to kind of jump on the platform and try to hold it up. And similarly, it wouldn't make sense to just jump on the train and kind of keep going with it. But what you want to do is just stand back and really watch it go by. And they have made the experience that the memories are actually quite brief. So just kind of stand there and observe it going through. It's kind of more detached attitude to intrusion. And that takes a bit of practice. Not everybody can do it right away, but people get the idea, and then they experiment, they get better with it. Some report a really big drop in intrusions right away, but just this different attitude to intrusions is very important. I should say there's one exception. There are some patients that ruminate all day long, and for them, I think we need to first introduce the distinction between rumination, like these kind of thoughts, what if I'd done differently, why me, and so on, and because we don't want them to see this exercise as a permission to do even more of the rumination. So for them, we wouldn't give that homework right away, but go and explain about rumination and the distinction with enough time, so that they really can make that distinction and really actually probably work on the rumination first. But many patients have some rumination, but it's not as all-consuming as we see in these people. And for them, this homework assignment is helpful. And again, with the hope, we can do something about it. It's not like being stuck in the trauma. We can actually help people to do things differently. The experience from the thought suppression experiment can then also be shared with the patient in a vicious cycle model. And here you see an example from a paper by Jennifer Wild that you also find in the COVID part of our website. In this case, the patient was traumatized by a near death of their father, and the image of the father struggling to breathe and the memory of him being close to dying led her to feel really terrified and out of control, and she tried to push these thoughts away and also ruminated about this event. And the thought suppression experiment showed her that suppressing her images of the father struggling to breathe actually made them pop into her mind more. So it stayed on her mind constantly. And this was the fast effect that she experienced in the thought suppression experiment. But then in the longer term, these strategies also then mean that memories are not properly put away and as part of the past, and they keep coming back into their mind even if she doesn't want to think about them. When we discuss the implications of the thought suppression experiment with the patient, it's also a good point to introduce the idea that we need to do some active work with the memories to make them intrude less into their everyday life. And again, we like to work with metaphors here, and we especially like the overfull cupboard metaphor, because everybody has the experience that if you stuff too much things into a cupboard, that there's a danger that the door will open and the content of the cupboard is falling out. And in order to actually then prevent it from falling out, you could do what the patient is doing, as just standing there holding the door closed all the time, which is a lot of effort, and it really preoccupies you and you can't do anything else. And this is what the patient has been trying to do so far. Or alternatively, you need to sort out what's in the cupboard and put it all in its right place. And then you can close the door and you don't have to push against it anymore to keep it closed.
Do you remember when we talked about the linen cupboard last week?
Yeah, that it's untidy and things keep falling out.
Yeah, that's right. Well remembered. So trauma memories are a bit different from normal memories because they're harder for our memory system to put away. And sometimes as a result, they can keep popping out when we don't want them to. But rather than just trying to jam the door of the cupboard closed and ignore what's in there, we actually need to sort out what's there and tidy the cupboard up so that we can close the door on the memories. So we need to do the same thing with the trauma memory.
And how would we do that?
Well, one place to start would probably be to talk a bit more about what happened that day.
This cupboard metaphor is I think, useful because everybody has this experience that if you stuff your cupboard too much, then eventually the door will open and things will fall out. And I think it also is nice because it really gives the idea that it's a lot of effort that you need to put in to keep the door closed, otherwise these memories come out. And then sorting it out is something that people can also relate to. So that's our favorite one, but you can also use other metaphor like a jigsaw puzzle that has fallen to the ground and so on, and you need to put the pieces together. But and some patients relate to other metaphors that are more close to their everyday life. But I think the basic idea, I think it's an effort to keep the memory, to suppressing the memories, and we have to do something differently now. And then that leads me. We're nearly at the coffee break time, but I'll finish with the Reclaiming Your Life intervention. I mentioned already that it goes through all the way through treatment, but we work with the patient on identifying aspects of their life or activities that they have given up since the trauma. It may be something that they actually couldn't do after the trauma. Let's say somebody enjoyed playing football and they had a leg injury, so it wasn't possible, but actually now the leg has healed and they can play football again. Or if it's a more permanent injury and football is not possible anymore, they could do some other exercise to like cover that same part of their life activities that used to be enjoyable and meaningful to them. And there is a general appraisal that many people with PTSD have that we call permanent change. So people feel that they have completely changed since the trauma, they're a different person. They often actually also say they can't remember their old self, what they were like, that was a different person, I'm now different. And that also has to do, again, with memories, because people with PTSD have trouble, they have this over-general memory bias, like people with depression, in that they can't really remember specific events from their life very easily. And just doing these activities gives them many more retrieval cues to remember what it likes to be their old self. So it helps with that as well. And we really start in the first session because it gives them hope and is something that they see, I can work towards my goals already now. And here's some of the simple things that you might want to consider. So exercise we already covered, but like people who have children, for instance, will often say, well, I just retreat in my house or hide away in the room upstairs, watch TV, and they don't really engage with their children so much anymore. And and just like going to the park with their children, playing a game with their children, something that they did before can be easy to do and easy to organize activity. They may have lost touch with their old friends. They need to bring them up. Sometimes like lost touch with their family. That's something we would want to work towards. Those that have lost their jobs might want to start inquiring about either applying for new jobs, but also, or if they need other qualifications because they can't do that old job anymore, maybe inquire about courses or go to the library and borrow a book about something, an area you're interested in. So really small steps. It's not important how big the step is. It's just like to get them going again, re-engaging with their lives. And I should say, reclaiming implies, well, there's some life to go back to. There is obviously people who really can't go back to their old lives, or their old lives were actually quite traumatic. And for those, it is about, we wouldn't say reclaiming, but rebuilding your life. But the idea is the same. You start in small steps and do things that they might be interested in and that might give them some sort of pleasure and joy. And the next slide just has a few questions about how we get towards these activities. What did you enjoy? What was important to you? What was a typical week like? And that's actually often quite interesting because you also discover that people were quite resourceful. They might have been quite sociable before the trauma, but the person who comes to you in treatment is very withdrawn and doesn't do any social activities anymore. So you get a bit of a better understanding of the person they used to be, and they may have skills and resources that you haven't heard about that only come out if you ask them directly. And some suggestions for activities or areas of activities you might want to look at, like such what did they do for relaxation, for instance, what did they do in social life, hobbies, and so on. And finally, there is some people have blocking thoughts that make them quite reluctant to start activities. So it's important to look at those and identify them and work with them. So, for instance, in this case, so somebody might say, well, if I leave the house, I will be attacked again. I don't have energy, or I'm quite jumpy now. After people will actually think negatively about it, and then put them discuss this with the patient and look for evidence against this assumption, and then maybe also create some flashcards that they can actually have at home or have on their phone. We nowadays usually put their phone. So if I start with some activities at home, it might make me feel a little bit better. For instance, I can do little things that will give me more energy. And lots of people are jumpy because people probably don't even notice it or won't react to it. So that might be necessary to actually get the patient to engage in these activities. And this is an example of one of the patients that we've seen in our team. And she was quite depressed as well, and she had agoraphobia as well. So she felt, for instance, if I go outside, I will be attacked again. So she did things in her home first. And the kinds of things that she did are shown in here. She liked cooking. So she looked up a recipe and cooked a meal. And we found that quite often that people even give up these simple daily pleasures that don't take. Go for a walk with a park, read for a short time. And she liked to do things with her hand, buy some knitting wool and start a scarf. And we schedule them, especially if they are depressed, you need to schedule it quite carefully. And I have a little video of her at the end of treatment explaining how important that was with her. Do you still want to see that? Or yeah, okay, and I'll quickly show that.
During the treatment, I was encouraged to start thinking of myself again, do things that were important to me or good to me, think of myself as a person, and I believe it really did help, because I have to admit that I was thinking that I wasn't worth anything. So to actually do things for myself made me think of me as a person again. The fact that I existed, that those people that assault me are not the only one in the world, that I do exist, and I have a right to be here and to enjoy my life again. My psychologist encouraged me to do things that I liked, and I like cooking. So I was doing lots of cooking. I was also making jewelries, because I like creating jewelries. I do have some of them here. Yes. And it did help me, because I wasn't then wasting all my time thinking of the assault again. I was doing things that were interesting to me, making things, creating, which made me feel like I was alive again, that I was a person, that I was able to do things myself. It really did help.
Part of the treatment, and it links very nicely to also appraisals about being worthless and so on, and if you really do things for yourself again, like she said, that really made her feel she was worthwhile again, and there was also some perspective for life again. Okay, I'd like to start now with the memory procedures that we mentioned earlier, the updating memories, which is really one of the core procedures of the treatment, and it has 3 steps. So the first step and function of this is that we really want to access the worst moments of the trauma in memory. And you may ask, why do we need special techniques for this? Why don't we just talk to the patient? In our experience, you gain a lot of information, and you gain access to moments that the patient might not have shared with you or might not have accessed because of avoidance, and also because of problems with the disjointedness of the memories. And I should emphasize here that although some of the techniques have names that sound a little bit like inducing a flashback is certainly not the aim of it. It is just to engage with the trauma memory enough so that we know what the content of the worst moment is, what happened then, what the patient felt at the time, but also what the meanings are, because we want to change those meanings and update them with more helpful information. So that is really an important point, and to bear in mind. And and I think it's really better to talk about revisiting the trauma than reliving it, because reliving sounds too much like re-experiencing. And we really also want to use these special techniques to also help us link the problematic, the moments that have given rise to these problematic meanings to the information that we have now, so to lead to emotional shift. And I hope to demonstrate that in some of the videos, that we really, by doing this linking, really influence emotions. And the other function of using this special technique is that it can help us with the patient to generate a new perspective on the information. Sometimes the answer to these problematic meanings is actually in the narrative itself. Like we had the example of the ambulance driver who was confused about the order of events, and by reconstructing the order of events, we generated a new meaning. For some, and we also want to access these details that people may have forgotten or haven't accessed in a long time, that could be helpful. And for some patients, doing the memory techniques like writing a narrative or doing imaginary living can be also be used as a behavioral experiment, but I must say that is a minority. There are some patients that have very strong beliefs that the trauma, their reaction to the trauma mean they're going crazy, they're developing schizophrenia, or they have a brain tumor, and or they have their heart is now so weak that if they had any stress, they would have a heart attack. And there, with suitable work building up to this, actually engaging in the trauma memory this way can be a behavioral experiment. But for most patients, it's the first two that we're dealing with. Now, there are two techniques. I just mentioned their names. Imaginary living, that's a technique that Edna Foer and her colleagues use in prolonged exposure therapy. And the way it's done, we have basically taken from her instructions, so we do it in a very similar way, but we just don't do it that often. We just use it with the function to access the meaning and also to put the new meanings into the narratives, into the memory. The other technique is writing a narrative with the patient. Again, that's also used in other CBT treatments for PTSD. For instance, Patty Resig's treatment, cognitive processing therapy, used to have an element where people were writing a narrative and then expanding on that and thinking about what it meant to them. And in our view, both of them work. So they both have a useful for our purposes. If we have a patient who is very avoidant and hasn't really kind of engaged with the memory very much, imaginary reliving is a really good technique to access the emotions that are connected to the memory and to access details, and also then later on to produce this felt change in meaning. And we use it with most patients, and the narrative also has great advantages for some particular purposes. So, for instance, when people are confused about the order of events, it's easier to discuss the order if you're writing a narrative and if you're in reliving, because you have to go in and out of reliving to do it. Whereas if you're writing a narrative you're standing on the whiteboard and reconstruct what happened sentence by sentence, and then the patient says, I'm unsure whether this happened first or that, you can have a discussion before you decide what you put on your narrative. So that's kind of comes more natural. And it then also helps them understand how one thing followed from the other. A very pragmatic reason is that many traumas are really long, and you couldn't possibly relive all parts of it. So actually writing a narrative of an event that went on for, let's say, 5 days or so, and then you can still later on go to those moments that you identify as the worst moments and relive those moments, focus in on those moments more with reliving, that's very useful. For people who have multiple traumas over a long period of time, and timeline is also helpful, like looking into that in their life history. When did the traumas happen, and what other important life events happened in between, which could be like one step back, even from writing a narrative about a long trauma. So we have found that combination helpful for people with long traumas, starting with the timeline or the longer narrative, and then zooming into the important moments that come back and re-experiencing with reliving. And for people who have very strong dissociation, we talk more about dissociation in the afternoon because that's really important in PTSD. For people with strong dissociation, we actually prefer doing only a narrative. And you see me, I have some videos of me working with a patient where we wrote a narrative together, and then actually I read out parts of the narratives to her to activate certain moments in the memory. Often it's useful to do both. So people may do some reliving in the session, but then we may ask them to do a narrative at home as homework, and more details may come up while we're writing the narrative. And what's nice about the narrative too, another advantage is this is something people can keep and can refer back to when they later on when they left therapy, but let's say there's an anniversary and they get some more intrusions, they can remind themselves of the work they've done with the narrative if they find that helpful. Whereas listening to the tapes then would be, most people wouldn't actually willing to do so easily. So I already mentioned we don't want to induce flashbacks, so that's important to bear in mind. I will also show you some techniques this afternoon. If it happens in the session, it's not the end of the world. So sometimes we don't know something is a hotspot and people go right into a flashback. That's very rare in our experience, but it can happen even with all the precautions we don't do. It's still not the end of the world, and we can treat these people successfully. But we wouldn't obviously intentionally want to induce it. So what we want to achieve is a sufficient engagement with the trauma memory so that we can actually access what's in the memory and what the meanings are in an emotional way rather than a kind of journalistic style or police report style report. But we want them to be staying aware of the present situation. They are with a therapist this many years later, and they are in a safe environment throughout, so we don't want to lose them to the trauma memory. And the other thing to always say is that obviously the patient should have control over the process. You discuss carefully with them what you're planning to do, and they have control. They can interrupt it or stop it and go out of the reliving. Let's say you're doing it if they want to. And I think that is especially important for people who have had interpersonal traumas where the perpetrator forced them to do things or did things to them that were very unpleasant. So we as therapists obviously want to always stay in the kind of on the side of safe people who don't push them so far. But on the other hand, we want to also, because we know that the technique is so helpful, we want to move things along and not be ourselves so hesitant. So we can be confident that these techniques are safe and helpful, so we don't want to anticipate, oh, this is going to be too difficult with the patient, so I'm holding back. So we as therapists wouldn't hold back, but we would give the patient control over how fast we go through it and how when they are ready to go to the next step. Most of you will be familiar with imaginary reliving, so I'm not going to talk about this technique in great detail, but just a brief summary of what it would look like in treatment, and we have some videos as well, is that first of all we need a rationale. We already talked about the overfull covered rationale, so the patient has to be on board, so we ask their permission to start with this work now, and if they have any doubts or any concerns, we would deal with them beforehand. So if a person, let's say somebody lost somebody in the trauma, somebody died, and they feel they wouldn't be able to stop crying when they had to remember the death, then we would talk about that before and get their permission to start when their concerns have been dealt with. And what we then instruct the patient to do is, if they can, close their eyes. Again, there's exception in dissociation. We wouldn't do that, but normally for people who need more engagement with trauma memory, close their eyes and then start at a point just before something started happening, go wrong, to a point where they were reasonably safe again or reasonably okay again. And go through the trauma from moment to moment, what happened, what went through their mind, how they felt, any sensory sensations they had at the time, from moment to moment, and really like a video in your own mind's eyes. You see the trauma unfolding in your own mind's eye, and then also, while they're doing it, give a running commentary so that the therapist knows what they actually is on their mind. Usually in the present tense, but we are actually not very strict about that. If the patient falls into past tense and we feel they are engaging with the memory, it's more disruptive actually to remind them all the time to talk in the present, and you can just maybe prompt them when it sounds like this is a hot spot or that they are hesitating now, and prompt them again So we wouldn't overdo that, but we want to have enough engagement. What's the therapist's role in that? Obviously, we want to make our presence felt by making supportive remark, you're doing well, how does it feel, and so on. The initial few times we probably would mainly do the supportive remarks, and then from the second time onwards starting prompting a bit more for feelings and thoughts. Because what we often find is the very first time people are not used to the procedure, they would fall into this journalistic or police report type style and leave out a lot of the emotion and thoughts. But we also don't want to interrupt them so much. So we kind of feel our way into it with every patient, and then later we can prompt them more. Like when there's a moment where you think, oh, this could be what we call hotspot, one of these worst moments, then we can prompt for what's going on in their mind and slow them down. And occasional ratings of distress, again, we don't, and nowness, we don't want to overdo this. And often we actually hold back initially with that and only ask it after we've done it. And later, when we know where the hotspots are, then we would ask for ratings at that point. And so how often do we do this? This is a big difference to the prolonged exposure protocol, where it's done a lot. In our experience, we need about 2 to 3 relivings of a whole event to get enough information to at least make a good start with working on the hotspots. So if it's a short event, that can be done in one session. You do a reliving, then you discuss what the worst moments were, what the observations were, what it was like, and then explore the meanings of the hotspots. And then we would move on to the next one. So for a short trauma like an assault or a road traffic accident, that could be all done in the same session. And then we now have really moved to updating what we call straightforward hotspots. It's none of them totally straightforward, but where the patient already has all the information that we need to update it, like they survived and they live with their children. So those ones, we would move to step 3 of the protocol right away because we have the updating information, and insert them into those hotspots. So let's say somebody is assaulted and that there are moments where we feel they are going to die, and then there are other moments where they are very ashamed. We would not wait until we have done all the work on finding out about the shame hotspot. We would update the one where they're afraid that they're going to die right away. And that then has the advantage that people will already see a relief, that moment will come back less in re-experiencing symptoms, and they might also sleep somewhat better. For homework, we give the patient a recording of a session to listen to. There are 2 exceptions. One is if people dissociate, we wouldn't want to risk them dissociating when they listen to the recording. In the session, we can manage that level of engagement, but we couldn't do that when they are at home. So we would do most of the treatment initially in the session. The other exception is that people who were unconscious or fainted during the trauma, as you know, any trauma reminder can bring back these physiological responses. So again, this would be a risk if they did it at home. So for those people, we would teach them l'assurance Öst applied tension technique first, so that they can safely listen to the tape. So how often should they listen to this recording? We initially ask them to listen to it a few times in the week, which might help them then retrieve more detail about the trauma. And also later when we come to the updating, to make the updates sink in more. But the repetition in itself is not the focus, because it's not an exposure treatment. So even if they only listened once, it could be very helpful. And we ask them for ratings of distress and nowness. We also ask them, is there anything that they did to hold back their feelings? Because sometimes you may find that people there's a moment that seems like it should be very emotional, but they actually kind of quickly go to the next moment. So they haven't fully engaged in that moment, and they were holding back their feelings, maybe. And this is just how we phrase this question. What do we look out for when people doing the reliving? We look for what could be the worst moments, and there it's really, really important as a therapist not to use your own judgment about what you would find most distressing about it, because our patients always surprise us that there is something about the trauma that they personally found the worst, which we would have not spotted if we didn't carefully listen to them. And they could, for instance, when they're coming to this moment, go very quiet and pause for a while, and you really see them kind of back in the memory. They could be very emotional, like crying or gesturing and so on. Or you would notice there's a gap. There's something there that they skipped over. So those would be the ones that we would probe more for, and really expect the same emotion that they had during the trauma. So somebody who was very kind of dissociated and wasn't really felt really totally emotionally numb will now not suddenly start gesturing and cry and so on, and they will go into this dissociative state at the time. And somebody who was drifting in and out of consciousness will also go very quiet and really feel like they're near fainting. So if you know what the trauma was, you already get probably an idea what possible emotions could come up, but observe the patient carefully while they're doing the reliving for signs of hotspots that you can then discuss with them. So our job as a therapist during the reliving is to facilitate an optimal level of engagement with the trauma memory, so that the patient engages sufficiently to access the emotions they had at the time, the thoughts they had at the time, but also then not being so emotionally engaged that they lose touch with present reality. If you haven't seen patients with PTSD before, it may be quite a daunting prospect to recreate some of the emotions people had during trauma, or potentially having people dissociate. I just want to emphasize 2 points here. One is that even if it happens that a patient dissociates in the session, and you will see a case example later, it doesn't mean we can't treatment, and this is a treatment failure. We just have to adapt the procedures so they can contain the level of engagement, so that they still can process the present reality and that they are looking back at the trauma memory. Also, just if you do it a few times, the reliving, you will see that the intensity of the affect and also the intensity of that sensation can also reduced over time, and that then can be especially enhanced if we bring in the updating information in the third step of the procedure. And finally, I want to mention that this level of engagement can also be very helpful for you to identify when one hotspot has several meanings, and that is often that different parts of the hotspot relate to different meanings, and you may have to update them separately. So going into this level of detail is really helpful in addressing all the hotspots the patient has. The narrative offers various ways of doing it. We liked doing it with the therapist standing at a whiteboard or sitting at the computer with a patient, and the therapist doing the typing. And and the nice thing is that you can really pay close attention to the emotional reaction from the patient from sentence to sentence. You can make pauses if you think they might be dissociating. You can also expand what you're discussing with drawings, like let's say they say I was driving and then I was hit, but I didn't know whether the car came from the right or left. You can draw the layout of the road and then come up with the most likely scenario. You could also do a little bit of reenacting if necessary to help probe the memory a bit. And then the patient can take the Word file or the document home and fill in more details so we can extend it. And sometimes we also, some of our patients are very used to writing, like the professional writers or some. For them, we would also sometimes just give it to them as homework, just in the basic treatment where they did it as homework. So this is the procedures we use to access the memories, and then we have the next step. We have identified the meaning. So how do we find the information that we need for updating the memories? We already talked about various examples where it's clear from the course of event that what the patient was afraid would happen at the time didn't happen, or it wasn't as bad as they thought. So that can be straightforwardly updated. Sometimes it is some information we retrieve through doing the reconstructing the event very carefully that gives us a new meaning. So we had the example already for a rape victim who complied with the perpetrator doing lots of things that she felt ashamed about, but actually she remembers he had a knife and had threatened her, so that would then explain why she reacted that way. And we had the examples that the perception actually wasn't true, like the toy gun, and we talked about expert advice needed. So these are all still very straightforward. But then it may also be needed that we do a few sessions just really working on the appraisals and tackling the appraisals from different angles. Like if somebody feels guilty, it could take a whole session or even maybe 1.5 sessions to really understand all the factors that contributed to the event and make their own contribution or perceived contribution smaller. And so this would be variable lengths, whereas these ones are usually quite straightforward to do. And that varies from patient to patient as well, how quick. For some people you can restructure guilt quite quickly, they get the point, and then you can quickly update the memory. For others it's really like chipping away at the belief, and you closely monitor your belief ratings. How much do you feel it was your fault? And until you get to a good point where intellectually at least they have agreed with you it wasn't their fault. And then you can move on to the next step, which is then a step that we introduced because we often had the experience that even if people had in the discussion with us as therapists agreed it wasn't their fault, or they had like now restructured their belief, you could say, it didn't make any, they say, well, yeah, I see that, I don't believe it anymore, but I still feel guilty. So then you could say, well, is cognitive theory wrong? that the thoughts trigger the feelings, but here the memories come in. That's why we need the work on the memories, because we have to link it to the right moment in memory. And that doesn't happen necessarily automatically. It can happen automatically, but in our experience, actually in most of our PTSD cases, it needs this extra step that we need to put the updating information, it wasn't my fault, let's say in this last example, into the memory. And how do we do that? So first of all, we can use the narrative we've talked about, and we can then highlight the hotspots in the narrative. So usually we often do it in a different color. And then at the right moment in the narrative, we put in, usually in capital letters and in red or some striking color, all the new information. So I now knew it was actually the perpetrator, actually what intended to harm me, and there was nothing I could do, and so on. And my own contribution was just being in the wrong place at the wrong time. That kind of information would then verbally be put into the narrative, and then we would then read it together, that the patient would read it out aloud if they feel they can't do it themselves, or the therapist might read it out to them. And we would then have them hold the original meaning in mind. It's all my fault, I feel so ashamed. And then when they have that moment activated in memory, so they really feel how they felt at the time, we then bring, oh, what do you know now? And then we read it out to them. And the idea is to hold both in mind at the same time. And that then makes this emotional link. And I'll show you a video in a moment that you can often really see it happening when the patient actually takes in the new information. we can do the same in reliving, going to the hotspot, bringing the hotspot to mind in reliving. And then when they have got hold of the emotion connected with the hotspot and the memory, we have various ways of bringing the new information in. Verbal reminders are the simplest one. I now know that I didn't die, for instance. But sometimes, actually, that's still quite verbal, isn't it? If it's something like I didn't die or I'm not paralyzed, actually feedback from your body is often much more convincing information for the patient. So you can actually get up, you can feel like your leg is healed and your body is not is working, you can feel your heart beating, and actually walking around, you can move your body. This proprioceptive information experienced at the same time that they think I'm going to die is often more powerful than just the verbal updates. Incompatible sensations could be something like having, like if somebody, let's say, had a lot of blood in their mouth and during the trauma and had the taste of blood, they could actually eat something with a different taste at that moment and really take in, oh, it's actually completely different taste now. I got out of this situation. Images are really also very helpful. I mean, I think they are the most helpful if the trauma involved somebody else dying, because there's a lot of patients when they lost somebody in a traumatic situation have this sense that this person is now stuck, like their memory is stuck. They have the sense that that person is still suffering and is stuck at this moment of dying where they had horrible pain and all the other things that happened at the time. And that actually also prevents them from grieving. And in therapy, we often find it very helpful to talk with them about their vision of afterlife, if people are religious, they might have certain ideas what happens to people now, like in Christian faith, we go to heaven, for instance, and then in other religions, other things, or people are not religious, but then still, I think you can come to the point where you realize that afterlife is somehow peaceful. The person is at peace, they are no longer suffering. And then come up with an image that represents that. So we have patients who then come up with an image, oh, like my child died, but it's now in heaven with a grandmother who already is waiting in heaven for her and is receiving her. We've had people who were not religious then imagine taking the person away from the site where they died. Sometimes like also not only the death was horrific, but also the whole surroundings were very distressing, and then taking them in imagery to a place where they, where a soul or whatever they imagine is left, that awareness is then in a place that they liked, a peaceful. It's like we had somebody who lost a young colleague in an explosion, and he had this idea that this poor young man, with all the promises and that were led of him, died in a horrible place. It was like an industrial site, very, and that he felt really very sad about it, and felt that this person was kind of sensing how horrible it was, what a waste of his life it was that he was now stuck in this horrible industrial state. And he decided he was going to then imagine him at a place where they had gone fishing together. They had that's something they had done in their spare time, going fishing together, and that was a place where he knew that this young man had been happy and peaceful. So that that image then can be put into the narrative or into it works better with reliving. You bring the hotspot to mind, the explosion happens and the young man is dead, and then bring in the image, like run on the image. We sometimes say, and if it's like you have to transport the person there in some imagery to the nice place where they are now at peace. And that's very powerful, and people find that very, very helpful. So you see that the updating in those sense in words is not like just facts, but you have to come up with an image that captures the meaning of the person is now at peace and they're no longer suffering. And then the last step is how they can remind themselves of the updates, and they could have like reminders on their phone, for instance, or remember this in other ways. So, for instance, if somebody died, they may have they may do something like planting a tree to remember that person by, and then whenever they see the tree, they remember that this person is now at peace. When we've done this, we usually see the symptoms go down. If not, we might have missed a hotspot. And we usually also do like one, towards the end of treatment, we do one more reliving or one more reading through the whole narrative to see that we haven't missed anything. Okay, so I think it's probably time to show you some videos about what it looks like. I will apologize for the real life patient videos because the sound is not really good, but they are chosen because they are brief and they also illustrate important points, but hopefully we can still get it even with the sound quality being very poor. So this is an example of a young man who is actually a refugee in this country, and the traumatic event happened in his home country. He had actually quite a few, but this is this is one of the traumatic events. He is a musician, and he wrote political songs in his home country and was persecuted for that. And in this particular event, he was driving in a car with a driver, and a car overtook them, and he was threatened with a gun, and he thought he was going to be killed. So it's a very, very brief video, but I just want to show you has already got to the point where he knows where the hotspots are. He's going to this hotspot where he's threatened with a gun, believes he's going to die, and he asks him now to update this memory with the information. He hasn't died. And what I'd like to for you to look out for is like the emotion that this patient shows when he's really hearing that information now. So, we talked about how when your flashbacks come into mind, they feel very much like it's happening here and now, and you're about to get killed. And that we can bring these memories more into the past if we bring in the information that you didn't die into this very moment in memory. Would you be willing to give this a try now?
Yeah, we could try it, yeah.
So let's think about when the best moment to start would be. Would that be when the car's overtaken you?
Yeah, from when I see the car, I think, yeah.
Okay, let's try that.
Okay.
So take your time, get ready,
Yeah.
and close your eyes, and then have a go.
Okay. So I'm in the car. I'm driving, and I can see this blue car kind of coming round, overtaking. And it pulls in quite close in front of me and starts braking. So I have to brake, and it keeps slowing down. And I don't know what's going on. Eventually, I have to stop. And I see the driver get out of that car and run over to mine and opens my door, and I see the gun, and I'm just frozen and just terrified. Can't move, and I'm just thinking, this is it. I'm gonna die. He's gonna kill me.
Well done. And what do you know now?
He didn't kill me. I didn't die. I was okay.
Well done. So that's what I wanted to show, that at that moment in time, when he's like remembering that bit of the memory, it comes as a total surprise to him that he doesn't get killed. And that's not unusual. So people say surprise or relief or something. So we really see like a shift in the emotion at that time. The same emotional shift can be achieved with the trauma narrative, and you see an example in the COVID part of our website. There is a video there. You can see here in the slide the trauma story that the patient wrote with the therapist. And just jumping to the hotspot, here it was a road traffic accident where the patient thought her life was going to be over in just a second. And then you also see in blue the updates that she worked on with her therapist. I know now that I survived, I'm alive. And there was additional detail to make this really come alive. So she did break her ankle, I needed surgery, but it was fine now, it has healed. And another important part of the meaning of dying was for her that she wouldn't see her family again. So part of the update also includes, I see my family, I see my sister, I see them a lot. And in addition to the verbal detail about what it meant that she didn't die, she also then, during the updating, looks at a photo of her sister, moves around, touches her ankle to feel that it's healed, to really make the information that they worked on in the updates sink in. I'll try now, because that will have better sound quality, to show you one of the videos that we did for our website. So these are now videos that are based on real patients, but we got one of our research assistants to play the patients so that we can use them on the website. And the example here is of a lady who was in a traffic accident and had to be transported into hospital in a helicopter. And she has already successfully updated a hotspot that was more straightforward, like I didn't, along the lines of I didn't die. But then the therapist notices, and there's another hotspot, and explores it, and it's a hotspot that she's quite ashamed about.
The patient has done a good job updating her hotspot with the new information. But as she continues reliving, there appears to be another hotspot. The therapist sensitively works with the patient to identify the new hotspot.
I'm drifting in and out of consciousness, and someone calls the paramedics or the police, and the next thing I remember is this really horrible sound, because they're cutting me out of my car, and then they put me on a stretcher, and they put a brace on my neck and my head, and they put me in a helicopter, and I need, and then we go to the hospital, and then.
How does the therapist know there is another hotspot? The therapist noticed here that the patient seemed overwhelmed and had skipped part of the narrative. The therapist gently probes for more information and finds that this is a hotspot linked to shame.
Okay, that's really good work, Joanne. So if we could just stay with that last part. So they put you on a stretcher, and they're putting you in the helicopter. Can you tell me what goes through your mind and what happens?
I really need to pee, but I can't move. So I wet myself. It's really embarrassing. I feel really ashamed. I should be able to control my bladder.
Okay, you're doing a really good job, Joanne. So you wet yourself and you feel ashamed and you think you should be able to control your bladder. What else goes through your mind?
That I'm disgusting. So embarrassing. Yeah.
And are these thoughts that go through your mind at the time of the trauma?
No. I think at the time I thought, oh my God, what's happening? And then it happens. And then I think I should be able to control my bladder.
Okay. So you think I should be able to control my bladder. And what happens next?
The paramedics are talking to me, and they're trying to sort of calm me down. And one of them is chatting to me, and he tells me that lying down is the best way to travel in a helicopter. It's the most comfortable way.
Okay. And where does the helicopter go?
Takes me to the hospital, and I see my husband there. And he looks really worried, but I feel a bit calmer. And then they do some tests and stuff, take some x-rays, and they tell me that it's just whiplash, and it's all right. And then they let me go home, and they say my husband can monitor me.
Well done, Joanne. Well done for staying with the difficult parts too. How distressing was it to go through the trauma just now?
Maybe about 40%.
And how much did it feel like it was happening all over again now?
Maybe about 50% numbness.
Were you doing anything to hold back your feelings?
Yeah, maybe at the bit when I'm in the helicopter.
Let's have a look at that moment in a little bit more detail. Is that okay?
Yeah.
The therapist and client work together to identify the thoughts linked to the hotspot and their meanings.
Situation. Paramedics place stretcher in helicopter. Thoughts. I have to pee. I can't move. I've wet myself. I should be able to control my bladder. Meaning. I am weak and pathetic and disgusting. When other people find out what happened, they'll think this too.
This sounds like a really difficult moment for you, Joanne. How much do you believe out of 100 I should have been able to have controlled my bladder?
80%.
And how much do you believe I'm weak, pathetic, and disgusting because I wet myself?
90%.
The therapist will construct a pie chart with the patient. This will help the patient to consider all the contributing factors that cause the behavior they feel shameful of. The aim is to normalize the behavior and painful feelings and reduce the belief that they are responsible or that it means something bad about themselves. Therapist and patient generate many reasons that could explain the patient's behavior. They may call in experts or expert sources to discover updating information. They may already know this information, and the therapist may share their knowledge where appropriate. Here we see the therapist use Socratic questioning to explore ideas about why people may wet themselves after trauma.
So what may be some reasons why people may wet themselves during a trauma or a very frightening moment? Should we brainstorm these?
Yeah, I can try.
What reasons come to mind why someone may wet themselves during a trauma?
Well, maybe if their trauma was quite long, then they might need to pee anyway. But then if you can't move because you're injured or something, then you might end up wetting yourself.
And were you injured?
Yeah.
And was your trauma long?
Yeah, it was a few hours.
What may be some other reasons why people may wet themselves during a trauma?
Well, maybe there's something about a trauma that makes it difficult to control your bladder.
Yes, that's right. Emptying a full bladder is an automatic reflex when the bladder is full, but our brain has learned to override our desire to pee by keeping the muscles that prevent emptying very tight. During a trauma, our body goes into fight or flight mode, and the fear center in our brain overrides those that control the bladder, so we're much more likely to wet ourselves.
Okay, yeah, I didn't know that.
So it seems that when we're scared, it's completely understandable that we would wet ourselves because we're more likely to lose control of our bladder or our bowels. Constructing a pie chart.
To construct the pie chart, the therapist writes the reasons for the patient's behavior on the whiteboard. The therapist will list the patient themselves as the very last reason after all brainstormed reasons have been listed first. Listing the patient as the last reason is important because it helps the patient to consider all of the contributing factors rather than just focusing on themselves. The therapist encourages the patient to assign each listed reason a percentage so they add up to 100%. When the patient is listed as the last reason, there is less percentage available to assign to themselves, which can help to reduce their sense of self-blame. The therapist will then draw the pie chart according to the percentages the patient has listed.
So it seems when we take all the reasons into account, you believe you should have been able to have controlled your bladder 2%. This is a big shift. How much do you believe I'm weak, pathetic, and disgusting because I wet myself?
Probably still 60%. I still think that other people, when they find out, would still think those things.
How can we find out what other people think?
Well, we could ask them.
We could ask them. We could create a survey and give it to people. Shall we put our heads together for a moment, come up with some questions that we could email people to get feedback? Patient and therapist create a survey with questions to gain other people's view on behavior similar to the patient's and their concerns. The survey begins by asking the respondent to imagine a similar scenario. They are then asked how much they would believe the person in the scenario to be weak, pathetic, and disgusting. They would also be asked to give any other comments. The therapist typically emails the survey to colleagues to complete. The patient could also email the survey to friends or family to complete. In the next session, the therapist and patient will go through the survey responses, add more updating information to the hotspot, and insert the new information into the memory. So I have people's responses to the survey we created. What do you predict they'll think about what happened?
I think that they'll think that I should have been able to control my bladder and that I'm weak and pathetic and disgusting. 70%.
Okay. Okay, Joanna, I'd like you to read the responses. Why don't you perhaps read the first one out?
Okay. So it says, "It sounds like a terrifying accident. Of course it would be normal to wet oneself in this sort of situation. My granddad wet himself when he had a lorry accident. It's just what the body does during this sort of trauma. I wouldn't think anything at all bad about the person because they wet themselves. They are weak, 0%. Pathetic, 0%. Disgusting, 0%. Any other comments? I've read that animals wet themselves all the time when they're frightened. I think it is a really common reaction to fear."
Interesting. What do you make of this?
Well, I mean, I guess it looks like this person wouldn't think badly of someone who wet themselves.
Okay, so this person wouldn't think badly of it. Shall we see what other people said? So we've had a chance to go through everybody's responses on their survey. Taking that into account, how much now do you believe I'm weak and pathetic and disgusting because I wet myself?
I don't believe it anymore. 0%.
The therapist updates the hotspot with the new information.
I know now that there are many reasons why I wet myself after the trauma. My trauma and rescue were very long, so my bladder was very full. My emotional centre in my brain most likely overrode signals to stop me from wetting myself. It is a common reaction during trauma, and other people do not think badly about it, or judge people or me for having wet myself after my trauma.
The therapist and patient will insert the updating information into reliving. The updating information will include the reasons why the patient may have wet herself, as well as the core summary from the survey, that other people do not judge her for wetting herself or think she is disgusting, weak, or pathetic as a result. The patient is encouraged to look at a flashcard with the new information for homework to remind herself of what she knows now, particularly when an intrusive memory of the hotspot is triggered or when she has a similar feeling.
It may take a number of sessions to update beliefs linked to shame, particularly if they are long-standing or if they're linked to early memories. Of course, how long it takes to update such beliefs varies from patient to patient. In all cases, the updating information should be inserted into the trauma memory.
Yeah, so I think this is an example where you see that for those hotspots linked to shame or guilt, we often need like a longer discussion and look at it from different angles before the belief is really triggered. So, and in general, I wanted to say about these videos, obviously they are a bit condensed. It's kind of to get to the essence of what the discussion was. In real life, the discussions often take longer, obviously, than we can put in a very short. But you see some of the techniques I've already mentioned, the pie charts on the surveys, which are really very helpful for that those sorts of hotspots. But then it's important to link them back into the memory. I just wanted to mention this one example of an interesting case of a young man, again a road traffic accident, and he had quite an unusual belief, and the belief was, I've lost my arm, although he hadn't. And again, another example, I think, how powerful these memories are. So what had happened is he was trapped in his car for a while and was stuck there, and it was all dark, and I think the airbag had gone open, so it was all the visibility wasn't very good, and he was kind of looking around, and he couldn't see his arm, and he was also kind of stuck behind. I think the steering wheel had come, so he was kind of stuck and couldn't see his arm. So in his memory, he felt he had lost the arm, and even though doctors had told him that his arm was fine to use and so on. Now, I think he came to us about 2 or 3 years after the trauma. So in all this time, he actually hadn't used his right arm. It was his right arm. He was right-handed, and it was his right arm. So he hadn't used it at all. He was just like walking and trying to do everything with his left hand, but obviously quite disabling. And so we then to discuss in the team what is the best way to update this idea that his arm was lost. Obviously, he knew he hadn't lost it because the doctors had told him it was fine, but his behavior also was so strong that that showed the memory was kind of dominating everything. So what we did is then, he also dissociated during the event, which made the memory even harder to change. So what we decided was that in a case like this, just telling him, oh, your arm is fine, wouldn't help us because the doctors had told him that many times before. So we encouraged him in the reliving and to first kind of touch his arm and feel it was there. So use the left hand to feel the right arm is fine, it's working. And then also start moving it while holding on to this hotspot in memory where he's looking for his arm and can't find it. So shall we work on this moment when you are in the car after the accident and you're checking yourself and you can't see your arm and think it has come off?
Okay, yeah.
So
yeah.
If you close your eyes,
Okay.
take your time to get back into that moment in the car after the accident has happened and you're checking yourself.
Yeah, okay. I'm in the car, in the passenger seat, and I don't know what's going on. I'm sort of checking to see I'm okay.
Mm-hmm.
But I can't see my arm.
And what's going through your mind?
I think it's come off. I can't see it.
And how does that make you feel?
Just scared, really, really scared and shocked.
Yeah. Can you see this through your own eyes?
I can see myself across the chair. I can sort of see me checking, and I can't see my arm.
Can you try to go back into your body so that you can see it from your own eyes?
okay. I'm in my body. I can't feel. I can't see my arm. I don't know where it is.
And how do you feel?
Just scared, confused.
Mm-hmm. What's going through your mind?
I think I've lost my arm. I don't know where it is.
Mm. Yeah, you're very scared. You think you might have lost your arm. Could you now move a bit so that you turn your head and turn your left shoulder so that you can look for your arm? What do you see?
I can. It's hanging. I can see it. It's sort of twisted and it's just dangling there.
So you can see your arm, but it's injured.
Yeah.
Yeah. Hold on to that feeling. You can see the arm, but it's injured. And could you now take your left hand and gently touch your right arm? How does it feel?
It's okay. It doesn't feel broken. It doesn't hurt. It feels all right.
It's fine now. It has healed.
Yeah.
Yeah. Your arm is there and it has healed. Maybe you can now try to move your fingers of your right hand a bit. Well done. Can you feel them moving?
Yeah.
And now move your arm a bit upwards towards your shoulder. Can you feel it moving?
Yeah, I can feel it.
Well done. Move it up and down a bit so that you can really feel it moving around. So, well done. How was that for you?
That was okay, yeah. Yeah, a bit weird, but it was nice to feel my arm. Yeah.
You felt it moving?
Yeah.
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 You felt it was not broken any longer?
Yeah. Yeah. Yeah, it was good.
And before we did this, you felt you had lost your arm. How much do you believe that now?
I don't believe that now. I know I didn't lose it.
Yeah.
I have it. Yeah.
So between 0 and 100%?
Oh, 0. I don't.
0.
Yeah, I don't.
Oh well, that's great. That's
yeah.
great. Thank you.
I think it still feels a bit strange. My arm, like
yeah.
it's not quite normal, but it's definitely there.
Yeah. And could you describe a bit more strange? What does that mean?
I guess it just feels a bit thin or short.
Yeah.
Not quite the same as the other arm.
Yeah, so it's a difference between your arms, and
Yeah.
the right arm is thin and small. How small would you say?
I mean, almost like a child's arm. It doesn't quite feel like it matches
Yeah.
the other one.
So quite different still. Yeah.
Yeah.
So let's work a bit more on this.
Okay.
His belief that he'd lost his arm had completely gone. So this doing it in the memory had really linked the two together. But the interesting thing then was that another belief had come up now, as replaced the original belief, and that was that he actually now he felt his right arm was much smaller than his left arm. So in those cases where there is like a distortion about what you look like scars that some people scars have faded, but they still see this in their own mind's eye. It feels like a bright red scar, or they feel they have a terrible limp, and people will see that, although you can't actually see it very well when you observe them. We use video feedback, like we also would do in the treatment of social anxiety, because their own impression of how they come across to others is so discrepant for what other people actually see. And we did that with this patient, and that helped a bit. He when he saw himself on the video, you could see himself moving his arm. The arm looks absolutely fine. And he was totally astonished and said, well, that's totally different from what he would have thought. And that brought down his belief of that the arm was much smaller from 80 to I think about 30. But there was still a belief left that the arm is small, so it's kind of vulnerable and so on. And so the next thing we did then is, like, he thought a survey might have, because he thought other people might still see it as much smaller. So we showed this video clip with his permission to a few people, and none of them could see anything wrong with the arm. The arm looked fine, it didn't look smaller. And we fed that back. That brought down the belief, I think, to 10%. But there was still a remaining belief, and we don't like it, like remaining beliefs, because then it kind of can creep up again. So the other observation then was that he had very extensive safety behaviors around his arm. So in his image, it was maybe not super small anymore, but it was still like vulnerable. And so when he was going down a corridor, he would always go very close to the wall, so that if somebody bumped into him and he felt he wouldn't really hurt his arm so much. So we worked on him with dropping the safety behaviors, and that then got rid of the rest of the belief. So that's what I mean with chipping away. You're kind of getting at the belief from different angles. The memory work is quite essential in this, but the dropping of safety behaviors in a case like that and the video feedback were very, very important additional technique that was used with him. I would now like to give an example where the updating information takes longer to put together, and where the trauma also involved an actual loss. So the worst thing the person experienced during a trauma actually happened. And in these cases, obviously, it is important to remember that the person has lost an important part of their lives. In this case, it was a lady who lost one of her legs in the trauma. And that significantly changed her life in many, many ways. And we have to remember that cognitive therapy is not about minimizing the objectively really negative effects of the trauma and really show our full empathy for that. But we can still help the patient by focusing on what is not lost and identify thoughts and about the trauma, meanings of the trauma and the loss and the future that are excessively negative, and where there is a distortion in the overall impact of the loss the person experienced. And here it's important to really again look at the meaning of the worst moments and the loss, and what the patient believes this says about themselves as a person or the world or their future. So one of the worst moments during a long trauma for this patient was when the consultant told her that they needed to amputate her leg. And the therapist explored with her that this actually had 3 quite different meanings. So first of all, it meant to her her life was really over. She thought, I will be bedbound or in a wheelchair forever. Secondly, losing her leg for her meant that she would be different, defective, and less than other people. And finally, she was a young woman and she had enjoyed to wear high heels and really dress up nicely and really enjoy being a woman. And losing her leg meant for her that she would never wear high heels again like what she called a proper woman, and she would be missing out on all the pleasures of being a woman. So each of these three different meanings was addressed in turn in detailed discussions with the therapist, with guided discovery and also behavioral experiments. The first one, that her life would be over and she would be in a wheelchair forever, actually didn't turn out to be true. She was able to learn to walk again, and she was also then reclaiming her life. She couldn't do the job she had before, but she did a college degree and also could then was planning to start her own business. So she rebuilt her life after the trauma and was able to walk again. The second one, that she was different to other people, took, again, guided discovery, where she really identified that there were many more similarities between her and other people than differences. And finally, the meaning she couldn't be a proper woman was replaced by really saying she had to really enjoy things in a different way. She couldn't wear high heels again, but she could enjoy many other things that women enjoy, such as wearing nice clothes, getting a haircut, or using perfume. And she built that into her daily routine to really remind herself that she was still a woman and could enjoy things that other women enjoy. So these updates were then linked to the hotspots in memory, including the one where the consultant told her she had to amputate her leg. There were several others, as you can imagine, on the way. And she also then reminded herself regularly of these updates. For instance, that she could walk about by walking about, looking at her college diploma to see how she had rebuilt her life and how she was actually more similar to other people than she had thought. And also reminding herself that she could enjoy the same things that other women enjoyed, except for wearing the high heel shoes, by putting on some nice clothes and using her favorite perfume. We talked about triggers of intrusive memories and other re-experiencing symptoms, and highlighted that it is often sensory cues that remind people of the trauma, and that these triggers are very highly idiosyncratic. Nevertheless, there is quite some commonalities about triggers for people who have been through various types of traumas, such as personal assault, road traffic accidents, or sexual assaults or rape. And I would like you to think for a moment about the types of traumas that you have observed in your patients, and importantly, thinking about those less obvious triggers that are sensory, and really think about all senses here, like visual cues, sounds, smells or taste, or physical sensations such as touch, or also body posture or movement. Yeah, so let's just put a few of your ideas together. So if we go by trauma, so about assault, what kind of triggers have people come up with? Yeah. Mm-hmm. And the ones you mentioned here are very typical examples that if a patient says, I don't know, we could make a start with kind of having some ideas, like for road traffic accidents, for instance, we could bring sounds into, play sounds on the computer to see whether that evokes any memories, or people like somebody who's been assaulted just walking up and down the street and seeing whether there's any other people that kind of bring up intrusive memories, and is it the way they look, or is it the way the angle you come towards it? So doing detective work is really one of the core messages here. So it's really a collaborative effort between the therapist and the patient to identify triggers. And what we can do is we can look at a recent intrusion that somebody had and let us tell them, well, what was the context? Was there anything that could have reminded you? And also do a bit of education about the types of triggers we're looking at, because the patient might understand us looking for meaningful triggers, whereas we're looking for the sensory overlap. We would ask patients to keep diaries to give us hints, but often we also make our best guess and bring a few things into the session to teach the technique of discrimination. So let's look at an example here. We had a lady who had actually was at her GP, and there was a gas explosion, and when she came to treatment, she said, seeing fires on TV and talking about the explosion. Those were the only triggers she identified. But if you then look at our list here, the things we identified throughout treatment is really very extensive. So anything to do with flames, light, flickers of light that are like in a flame, fireworks, explosions on TV, the sight, somebody mentioned the sight is an important one, anybody who was around at the time, firemen, fire engines, paramedics, so even the people who are coming to help can be associated with that. So like often we have people responding to aspects of the uniform of policemen or firemen and so on, and it can be really specific, so to find out exactly what it is. But the internet now makes it so easy to show people lots of pictures and say which one makes you more apprehensive. Anything with loud noises, and yeah, there was also a specific hissing sound. So that's like a very specific one again, like the sound that came from the gas cylinder. Anything to do with smoke and burnt food, but then also the difficulty breathing that she had at the time became a trigger, and that's sometimes quite tricky if you have like the heart difficulty breathing is also like a symptom of when you get anxious, and it can then kind of escalate to panic attacks. And this lady had comorbid panic disorder as well. And anything to put on her face, because she had to have she was putting on the oxygen mask when the explosion happened. So those were her kind of triggers. And once we have identified only one of them, we can start working on the technique with the patient. The idea is to break the link between this trigger that is there in the present situation and the trigger that as it was present in the event. And it is really has several steps. I think first of all people have to actually notice a memory has been triggered, because they will find themselves maybe suddenly only having an emotion that is similar to the trauma. And so they may suddenly feel a bit anxious or panicky or nervous, and then actually noticing that and then say, oh, a memory is triggered, and then look around what is similar to the trauma and what is different. And the technique is really an attention reallocation technique. So rather to recognize what the trigger is, but then also look at all the differences. How is the trigger different from the trauma, and how is the whole context of the situation different? And somebody mentioned somebody who looks like the assailant. That is a very common example we have, that people after an assault will tell us, well, I really don't want to leave the house anymore because there are people that look like the assailant everywhere, and I feel very threatened when I see somebody like them. And what we see here is that a combination of the easy triggering of the memories that bring back the emotions from the time, But then also the avoidance behavior, because people, once they spot there's somebody who looks like the assailant, will quickly try to get away. So they won't look, they will only have a very brief glimpse at the person, and then the memory is activated. So the only thing they're taking in is that the similarity. There may be, but then if you look at the person closely, there may be only one similarity. There might be a similar height, or a different, similar hairstyle, or they have the same type of jacket or something like that. Whereas if you look at them closely, you see all the differences. But the patient won't do that on their own, because they would be already crossing the road to not be close to this person. So we can often then use the discrimination to actually see, well, these people look different, actually, when you look at them again, and it's just really surprising how different they look to the patient. And that then also brings down the estimation that the world is full of people who look like the assailant. So that's kind of how we do link up the behavioral experiments together with the stimulus discrimination. Okay, so here we have another example from somebody who had a road traffic accident and was watching television, and then unexpectedly there was an advertisement on drink driving, where there were quite a few reminders. There were sirens, but like the brakes were mentioned before as well, and the sound of breaking glass. So there were quite a lot of overlap with the trauma. But when we then looked at all the differences with the patient in therapy, that's the usual pattern. You find some similarities, but lots of differences. And the idea is then to identify these differences and really focus the attention on those. So like in this situation, the patient was actually in the sitting room at home on the sofa at nighttime, whereas the car was on the motorway and he was in the driver's seat, and it was daytime, and they couldn't move, whereas now they can move. They were on their own now with the wife and kids. And again, trying to get some sensory information as well in here, so couldn't hear anyone speaking would be an example, whereas in the TV there's a voice-over on the ad, and also they were at home, so they heard their kids in the room next to him. So that's the idea, and I think I'll just will show you a brief video, and to illustrate that a bit further.
After Lucy's sexual assault, smelling male deodorant or aftershave used to trigger intrusive memories of her attack. She and her therapist have agreed to bring some of these cues into the therapy room to practice using then versus now. It is important that Lucy feels in control of this, as at the time of the trauma she felt very powerless.
Okay, Lucy, so when you're ready and in your own time, do you want to take the deodorant, open it up, and then have a bit of a smell again in your own time?
Okay.
You're doing really well.
I'll give this one a go.
Well done.
Okay, I think that one's fine. It's not triggering anything. I think this is a different sort of deodorant.
So it's quite a different smell,
okay.
that one. It's not triggering anything. Okay.
No.
Well done for trying that one. Do you want to have a go of picking another one to try? We've got some different aftershaves here.
Yep. Okay. I'll give this one a go. Right, I'm feeling a bit nervous.
Understandably. Well done.
Yeah, it's that one.
Okay.
It's that one. I can feel myself getting pushed up against the wall. I feel like he's here.
Okay.
My chest is getting really tight.
Okay, so well done, Lucy. So that's the memory talking. So let's see if we can try and focus on what's different now. So for example, where are you right now?
Okay, so I'm in the clinic.
Yeah.
You're here.
Yeah, well done. Yep.
It's a different time. Yeah. This is just perfume. Yeah. The attacker's not here.
Excellent. So you're noticing lots of differences. It's important you're not being attacked right now.
No, I'm safe. I'm safe right now.
Well done, you're safe now. Any other differences we can think of at all?
Again, you're here. It's just us two here in this room.
Excellent.
I'm safe.
Yeah.
The trauma's in the past.
Good.
I can move my arms.
Yeah.
no one's attacking me.
Wonderful, well done, well done.
As Lucy was trapped in her trauma, her therapist asked her to move around to show herself it is different now.
And remember again, just reminding yourself, what's different now, Lucy?
So I can move,
Yeah.
I can walk around, he's not here, I'm safe now, you're here.
Excellent, you're doing really well.
The trauma's in the past.
Doing lots of kind of moving around, just showing yourself there's nobody in front of you.
Yeah, so this slide now summarizes what we're doing. So we would probably start with looking at a recent memory, find a trigger there, then you kind of bring into the session anything that's suitable, images, sounds, videos, smells, tastes, to practice together, then together practice it with the therapist in the therapy room and then outside, and then they can take it on themselves. And we find usually once people have really learned this technique, they can then also apply it to unforeseen triggers that they encounter. But that needs to be practiced quite a lot before they can do that. Okay, so I think the stimulus discrimination fits well then with talking about dissociation, which has come in some of your questions already. It's something that we need to be aware of. And as I said before, when it happens in the therapy session to the extent that people lose complete contact with their current surroundings, it's actually not helpful. It can also be a bit of a setback for people. So what do we do with people who dissociate? Like if we know it right from the start, we would normalize that bit as a common response and link it to the kind of freezing response that animals also have, as I've said before. I also quite like this. There's some drawings by Frida Kahlo that you might have seen. Frida Kahlo, the Mexican painter, had a bus accident and was severely injured. And she has these drawings where she kind of is then on the pavement, like with all her wounds, but she's also floating above herself. And I think that's a nice illustration that is like even this painter has already put it in her drawing of her own accident. So it's such a common thing to happen. So how do we adapt the treatment? First of all, we find it really useful, and that links a bit to your question about do you do something to prepare people for the memory work. We would do the trigger discrimination, so what we've just done before we start with any reliving or narrative writing, because we want to really make sure that people can master this technique so that we can briefly get them into the present again, and also kind of are aware that the dissociation itself is a memory phenomenon. Like with the trigger discrimination for intrusive memories, the techniques that help the patient stay in the here and now are the same for dissociation. So any sensory cues that anchor them in the present, objects that they touch, for instance, a toy that belongs to their children, photos or videos of recent events, smells, tastes, or they could have self-instructions about how they are safe now recorded on their phone or the flashcard with reminders that the trauma is over. Moving their body is also a very good way of keeping in the here and now and feeling really their body alive in the present, especially for people who dissociated and couldn't move while they were dissociated or if they were unconscious. Also, looking around them and moving their head to look around them and see what's in the current situation, especially moving objects are a useful reminder of the present. And finally, it is helpful to look out for signs that the client is starting to dissociate that you can observe in the session, and they are individual for each client. And then we can also teach the client and possibly their family or partners what the signs are that they are about to go into the dissociation, so that you in the session and the family can help them initially, and then the client later on is also be able to spot it and then use the then versus now techniques to stay in the present. In the session, the therapist's voice is a very important reminder of the here and now. They didn't know you before the trauma. So talking quite frequently so that your voice keeps reminding them where they are, and also in what you say, remind them of the here and now, can also really be helpful in the session. So what is different if somebody tends to dissociate? We would use a more graded approach. So that's why the narrative writing seems a good technique to have like total control over the distance, how much people engage. And we have some patients where we really like write 1 or 2 words at a time, and then we talk about everyday life now, which you could say is a distraction technique, but it is really has the function to really keep them anchored in the present so that they can look back at the trauma. Timeline I already mentioned. Yeah, so it's really sentence by sentence, and then use the then versus now techniques similar to what you've just seen, that you're not back there, do the movement if possible, holding object smells, and really also pauses are totally fine. It doesn't mean you're not doing productive work, so you don't have to rush people through the whole narrative quickly. It can really take a lot of time, and that's time well spent if you get the information out what happened and also get a good idea what the hotspots are. Then it doesn't matter if it takes a long time to write the narrative, and you might not finish it in one session. You might need to come back to it in the second session. So taking our time to do this, the narrative is our preferred method, but you can also, for those with milder levels of dissociation, can use modifications of reliving that basically keep them more aware of what's happening in the present. The eyes open is one possibility, but that might not be enough. Some people like having then kind of get this kind of, they just stare, and that's more like staring into the distance, and they see in front of the inner view, in the eye, they see the trauma again. So we also find that actually moving around is good. And in the tape with my patient, you say she was actually when she got into memory loss, she couldn't move anymore. So, but then we found if I move, so she kind of looked at me moving around in the room, that helped. So a bit of, I would say, a bit of trial and error what helps, but you get to know a patient better, and that's, I think we need more sessions with people who are severe dissociators to really get the level of engagement right, and to know them so well that we do productive work on the trauma memory, so that they are engaged enough to make changes, but not so much that they're losing contact with the current reality. So moving then versus now again. What we've also sometimes find helpful is like changing the perspective. So it could be like going into your body again. I think I mentioned it as well. You're kind of seeing it from the bird's eye perspective, and you're going into your body. But for other patients, it can also be other way around, that they kind of look at the whole situation from a bird's eye view, maybe not just in imagination, but also drawing it out to give them enough distance to take in what the situation was like, what happened one after the other, but they're not overly engaged. So these are some hints that we can do. And when you're working with people who dissociate severely, you may also find that the updating may take a little bit longer to emotionally sink in because of the dissociation. You may need to experiment a little bit with a patient to find the right channel on how to make the updating really emotionally make sense during the dissociated state. That may involve adjustments in wording you use, or an adjustment in the images, or maybe also physical cues such as moving about. And I think it is important for you not to give up. So if it doesn't work the first time, it doesn't mean it won't work. And I will show you an example of that. So if you find the right way to do the updating can have very big effects in people who dissociate as well. Another important thing to consider is that people who are dissociated often feel really numb. And as part of the reclaiming your life or rebuilding your life assignments, we would also make sure we include some self-care, like taking your time to take your bath, using some body lotion and so on, to really feel your body in a positive way after what had been done, for instance, in people who were sexually assaulted or abused. And importantly, we also need to make sure that the patient is safe, not only in the session but also in everyday life. So that may include risk plans. What would we do if they have ideas about self-harm? And it might also be useful to talk with the patient's partners or family who they're living with about how they could help to keep the patient safe while they are in treatment, and maybe signs of dissociation that they could then learn to respond to, and use the then versus now technique to bring them out of the dissociation. Now, we often get asked the question of whether we train people in emotion regulation strategies before we engage in the memory-focused work. And we don't do that. We use the techniques I described, the stimulus discrimination, trigger discrimination, and also the careful way we do the memory work to really try to work on the memory as soon as we can, because we know that the treatment is so effective that it will dramatically change the re-experiencing and the patient's emotion if we get it right. But other researchers and clinicians have had good experience with using emotion regulation training before exposure treatment. For instance, Cloytre has suggested that a phase of emotion regulation and interpersonal skills training before doing prolonged exposure. But the field is kind of divided as like examples of both strategies. The narrative exposure therapy, for instance, also doesn't include stabilization before starting timelines of the traumas. So, and it's really research questions whether the stabilization is always needed. In our experience, we can manage the patient's emotion with the techniques I just described. And you will have gathered from what I said before that we can adjust the order in which we do our interventions, for instance, by doing the stimulus discrimination techniques first, which then enables staying more aware of the here and now during the memory work, and also working on some appraisals, such as the ones related to shame and high self-criticism, in a light touch way before we actually then go into the details of the trauma, which helps the patient to really regain some of the external perspective that we talked about when they're doing the memory work. I'd like to now share two examples of patients that our group treated that showed very high dissociation in the treatment sessions, and also to show you that the treatment works with these high dissociators as well. So this is a first case is a gentleman who was a refugee in the UK, but the trauma really, and so he had previous traumas, but the trauma he came to treatment for was an assault in his own home, and it happened when somebody knocked at the door, and they opened the door because they had ordered a takeout delivery, and they opened the door, but it was people who, in a case of mistaken identity, then assaulted him and his family in a bad way. He dissociated a lot and had PTSD and major depression, and in the treatment we discovered many different triggers. For instance, any kind of sounds that were similar to the knocking, anything to do with doors or doors opening, and also lying down, because in the trauma he was knocked down, so he was lying on the floor, and so on. And what also happened then was that the treatment was hard, because some of these triggers were also around in the clinic building. So you hear doors opening and there were knocking sounds and so on, which then could trigger the dissociation in the session. So treatment then first involved identifying signs that he was going to dissociate and the triggers of a dissociation. And the therapist found that he had assumed a particular posture when he was starting to dissociate, which was putting his head down and then holding it in his hands. And whenever he started to assume this position, and she could remind them of the here and now. And when they identified the triggers that were around in the clinic building, then they could do something about it by using a different room. On some busy days in the clinic, they actually then decided to do the treatment outside in a park, where there wouldn't be these door noises and knocking noises that were in the clinic. And they also then learned other ways to keep him in the here and now. For instance, they found that using a ball and actually throwing it between them and catching it while working on the trauma memory was a good way to anchor him in the present. So there was quite a lot of trigger discrimination work before starting the memory work, and the memory work then could start with a timeline written narrative on a whiteboard before they could do the updating then, including some imaginary living to incorporate the updates into the trauma memory. And this is another case, a patient of mine who I treated a while ago, and her trauma was being assaulted at a party at in her neighbor's flat several years before she came for treatment. She also had comorbid panic attack and major depression and agoraphobia and very severe dissociation. And we had no initial warning about the dissociation because she hadn't mentioned anything about dissociating in the initial assessment. And she hadn't mentioned that actually the trauma was quite prolonged, because not only was there the assault, but also there was a traumatic court case following the assault where actually she was blamed for the trauma in the end. And also after that, daily threats for another two years while she was living in this building. So she really felt daily that she would be assaulted again during that time. So in the first reliving, when we attempted that, because we didn't know about the features of dissociation, so we couldn't prepare her like you've seen in the other case through the lot of then versus now work beforehand. She dissociated very extremely, and she collapsed on the floor, and I had to then talk her out of the dissociation by reminding her where she was and that she was with me and she was safe. The dissociative symptoms also included, we found out, that she sometimes couldn't move, she couldn't open her eyes or move her shoulder, and she also had strong pain on her forehead where she had been hit during this assault. And finally, she had a phenomenon that we have seen in some patients who dissociate very severely, where the sensory information from the trauma gets superimposed on current reality. And in her case, it was what she saw people's faces going round, because during the trauma, she had seen people with round faces. And people's faces going round was very threatening to her. She felt that she was going to be attacked again. And unfortunately, that also happened with me as a therapist. So my face would also sometimes go round, or she would see my face going round when we were kind of going into the trauma memory in our work. luckily my face stayed white, and she could always recognize my voice as my voice. She hadn't known me before, and she could always know that I was Anke and I was a safe person for my voice, but my face was sometimes looked threatening to her. So we found a way around this by a bit of trial and error, in that when she looked into a monitor I had in my office at the time, she called it the mirror. So when she saw my face going round, she could look in this reflection of my face in this monitor, and she could then see there that I was Anke and I didn't have a round face. So this is an example of somebody where the perceptual information from a trauma intrudes in current reality and made her really feel threatened. And that often also happened when she, for instance, when she was on the bus coming to the therapy sessions, and really made her very apprehensive in the bus, and sometimes she felt somebody was going to attack her, and then would sometimes be also aggressive towards other people, because in her view, as self-defense. So as part of the work of finding out what her triggers were, it was often something coming from behind, because when she got knocked on the head, the person had approached from behind. So we did some trigger work leading up to the homework assignment I just gave you. It was prepared quite carefully, and it built on the observation of people's faces going around, and she not being able to take in anymore that these people are safe and won't attack her. And it was something she had described when she was riding on the bus. She often felt under threat, and people's faces would turn round, but she had noticed that it didn't happen to babies. So as one of the experiments we're doing using this trigger discrimination in the session, I asked her to, next time that happened, that she had a chance to be on the bus with a baby and she liked playing with the babies, then she should look up at the mother and really try to remind herself that this was the baby's mother, and she was not somebody from the party, she was the baby's mother. And I'll show you a brief reenactment of what she describes how this experiment worked. So we discussed last week to try the then versus now technique when you're on the bus, and when being around other people makes you really anxious, and sometimes even if their faces go round, which makes it really scary. And we thought a way to start would be when you're playing with one of the babies there, to take a look at the mother and really take in, oh, it's only the baby's mother, I'm safe here, I'm on the bus. Did you have any chance to try this out?
Yeah, so that exact thing happened on the bus actually. There was this really cute little chubby baby, this really little beautiful baby, and the baby was smiling at me, so I kind of started smiling back and kind of waving my hands around. The baby kept smiling, so I told myself this is a good chance to kind of do this, kind of be brave, just look up, it's just the child's mother. So I looked up really quickly, but the mother's face was round, and my heart kind of started pounding. So I looked away really quickly again, and I kind of was ignoring the baby for a little bit, but then I could see that the baby was still kind of smiling, so I started kind of waving my hands again, and I told myself, you can do this, you're on the bus now, you're not at the party, you're safe now. So I again looked up at the mother, and I did just exactly what you told me to do. So I kind of smiled quickly at the mother, looked away, looked back again, and her face was normal. It wasn't round anymore.
That's wonderful.
Yeah,
That's
so
really
I kind of took a big sigh of relief and eased into myself, and I was thinking kind of before, was I doing a bit too quickly, perhaps?
Yeah, I think that's a really good thought, because if you look at somebody really very quickly, you mainly take in what your memory tells you, and in your case it was at the party there were people with round faces, and that's what the memory told you was happening now. but that wasn't the case, was it? You were on the bus,
Yeah.
and it was the baby's mother.
Yeah, so I did exactly that. Told myself, I am on the bus, I'm safe now. And, you know, the mother actually smiled back at me, and she actually started talking. She told me she liked my earrings. So.
Oh, nice, that's lovely.
Yeah.
Wonderful to hear that, well done.
Thank you.
It's such a surprise that this person is not threatening, the one who looked round, had a round face before in her view. And it also, I think, illustrates how powerful these memory phenomena are. So first when she obviously had thought about it and had realized was the first time she looked too quickly, so she only saw the round face, and she didn't really have enough time to really fully take in, oh, this lady looks different, and she is the child's mother. And that was really encouraging for her, because she could use that from then on. She could then also use this technique more for other people in the bus. So I think that was a nice example of using the stimulus discrimination, even for people who dissociate a lot and have these perceptual changes in their that are kind of superimposed on the current situation. Let me now tell you what other memory work we did with her. So first of all, the reliving was a trigger for dissociation. So we learned from that we needed to approach the memory in a much more graded way. So what we did is we wrote out a narrative together, with me typing and looking at my computer screen and really going slowly, sentence by sentence, and focusing on the present, and really discussing what the next sentence was going to write very slowly. And when we had this narrative written out, she was not really happy to read it out herself, but I read out the narrative to her very slowly, and taking frequent breaks, and then using a lot of techniques that we had worked up through the work on the triggers that we knew would help anchor her in the present. So my voice, as I said, was a strong reminder of the present. So I was talking a lot while we were also then working through the trauma story one sentence at a time. She could look, I already said that she could look at me indirectly by looking into this monitor. We frequently made her move her head and her shoulders, because the closer we got to the hotspots, the more she would feel she was freezing up, not being able to move anymore. She had her eyes open all the time. And we also used drinking water, and we tried perfume first. That was a pleasant smell that she anchored her in the present, but it then also gave her some feelings of breathlessness, and she had felt breathless in the trauma, so we abandoned that. And we also found that while she couldn't move much when we were doing this work, but if she watched me moving around, that was also helpful in anchoring her in the present. So initially we read out the story slowly, and she was able to stay in the present with using all these reminders, and I checked that frequently. But that helped us then to actually identify the most important hotspot of this assault, which was that she felt she had died in the trauma. And that was because once she had come around, she was unconscious, and then she came around from being unconscious. She couldn't initially open her eyes, and it took a while for her to be able to do that. And when she then was able to open her eyes, she saw all these people standing around her, and she didn't recognize their faces. And obviously these were her neighbors, so she wouldn't have normally known these people. But because she couldn't recognize them, she felt the only explanation could be that she had died and she was arriving in heaven, because she had seen in films that when you arrive in heaven, the angels are standing around you. So before we've talked about examples of patients where the updating a hotspot, I died, was very straightforward because people know they hadn't died. But in her case, contributed by the dissociation, she really still believed she had died in the moment. And she was kind of getting on with everyday life, but she felt very dissociated much of the time, and she really felt she had died at the time. So we had to really work hard on finding a convincing alternative for her. And that involved detailed discussions about alternative interpretations. And in the discussion, we first we were looking at like when you're coming around from deep sleep, you take a while to really take in where you are and who you are with. But that didn't really seem convincing. And in a further discussion, we talked about feeling unconscious, and when you wake up from unconsciousness, how the senses come on one at a time, and that it takes a while for your brain to start fully taking everything in. But again, the word unconsciousness didn't convince her so much. And I mentioned then the word coma at some stage. But that was something she could relate to because, again, in a TV program, she had seen a report about somebody who had been in a coma for a long time and then was waking up again. So she could, in our discussion, believe that actually she hadn't died, but she had been in a coma. So then we tried to put this information, I had been in a coma, I didn't die, into the hotspot in memory when she opens her eyes and doesn't recognize people. But she then, when we discussed this, she said, oh, this is just words, I can't believe this. Which is an example of how what people can understand in the discussion and really also believe in the discussion with the therapist doesn't necessarily seem plausible to the person in the state at the trauma memory that we are working on. So we then discussed another, what else we could use to make it convincing for her, and then she herself suggested, I didn't die, which she could now believe in talking to me more, because we had talked about the coma hypothesis, but the word coma didn't seem plausible in the memory. So we had tried whether I didn't die would work, and that is now illustrated what she says and how she describes this experience about how the updating then actually sunk in the following video. So when we just worked on that very upsetting moment when you opened your eyes, couldn't recognize the people and thought you had died, and we brought in what we had discussed before, that this was because you had been in a coma and were coming around slowly. That didn't really feel convincing, did it?
No, they felt just like words. I didn't really believe it.
Yeah. Well, that's really very important to know. So that doesn't seem plausible to the memory at the time. So you thought then we might want to try just telling yourself, I didn't die at that moment.
Yeah.
Should we give that a try? Are you happy to do that? So I will read again up to that moment and then prompt you to tell yourself I didn't die. I heard people calling my name. Open your eyes, they say. I could not open my eyes. Someone shakes me. I opened my eyes. Everyone was looking at me. And then that was it. I did not recognize their faces. I thought I had died. And what do you know now?
I know that I didn't die. I know that now. I can feel it.
Oh, that's very good, yeah.
It feels more convincing.
Yeah.
When you said I was in a coma,
Yeah.
they felt just like words.
Yeah.
but this, I didn't die. It feels like there's something more behind it.
That's very good.
It's more substantial.
So it feels like it can believe it more.
I feel like I can really believe that now.
That's lovely. That's really good.
Yeah.
Well done. So I'm just wondering whether we should try it one more time to see whether that stays convincing when we try it again, and maybe also for to sink in even a bit more.
Okay.
Or is it getting a bit too much, and would you like to take a break?
No, I think we can do it now.
Okay, good. So when you're ready, I'll read again. Are you ready?
Yeah.
Okay. I heard people calling my name. Open your eyes, they say. I could not open my eyes. Someone shakes me. I opened my eyes. Everyone was looking at me. Then that was it. I did not recognize their faces. I thought I had died. And what do you know now?
I know I didn't die. I can really believe that now. It's like, it might sound silly, but I can feel it in my head. It's like there's a window opening up and taking in the information that I didn't die.
That's wonderful. So this is where you got hit, and so this is like where your memory is, isn't it?
Yeah, yeah.
So it could take in the information that you didn't die. Yeah. It's sinking in now, isn't it?
It's like my brain's accepting that, and then the window's closing again, and I can really believe that I didn't die.
That's wonderful. Well done. Yeah, so I thought that was really lovely description, like that she felt it so physically that where her memory was and in her head, that took in the information there. And I mean, we wouldn't just rely on her saying it now, but also observe then that the memories went down and the pain in the head got much better. So it was a sign that we had done the right thing. And in terms of the timing of the session, because I said at the beginning, oh well, if it's something to do with I didn't die, we might do it in the first session. So this was session 7 with her. So it took us 7 sessions to get to this point, to do the updating in that way. And we had a lot to do with in terms of dealing with her general safety behaviors and avoidance as well. But that was really a session where that really brought in a big step in treatment when we got there. And so that's my main message, is really with people who dissociate, you just try it from different angles and try what works for that particular patient. So if it so happens that something triggers a flashback in the session, then they are really back there, like he was, in a very dramatic way, and also I have to look out for our own safety, but basically talking to them non-stop, and really reminding them where they are, who they are with, and so on, is the best strategy, I think. And from what patients have described back to us is that at first, like even if you speak at the same level, initially it is very faint, so they might hear it as a very faint, somebody's voice far, far, far away. But if you keep repeating the same things, they come more into the room, and if they then have their eyes open, you can also direct their attention to what they can see in the room. Look, it looks completely different here. There's books on the shelf, or there's fit. So, but obviously at that point you didn't know what his trauma was, and yeah, I mean, I think that it is. I think it's always quite upsetting for the therapist as well if that happens. We have to acknowledge that, but it's good to know you can talk them out of it, and it might take minutes. Encourage them to open the eyes if they have their eyes closed, and then point that direction to look around you, and movement again, like different movement. So those kinds of general things, but I think I would go for, and touching would be counterindicated because often there's some touch involved in physical contact involved in trauma. Imagery can play an important role in both in generating, updating information and also then doing the updating so that it actually sinks in emotionally. An example for generating, updating information would be perceiving in imagery the situation from a new perspective. For instance, we treated quite a few survivors in the London bombings who felt that they should have helped other people more and felt really guilty about that. When they then went into the bird's eye perspective and observed the situation from above, visualizing that the emergency services were coming to trying to help people who were injured in the bombings, and then realizing that if they had tried to help, even if that was really not possible in their own state they were in, they were injured themselves and were psychologically obviously in a very frightened state. But if they then saw the emergency services were actually on the way to help people, and they would only have got in their way if they tried to get to the next carriage, for instance. That was very helpful information, seeing that help was on the way. They can also in imagery explore actions that they haven't taken. For instance, a typical example would be fighting back. Many people feel ashamed or feel angry with themselves that they didn't fight back more in an assault. And if they then visualize what would have been the consequences of fighting back, they often realize that the outcome would have even been worse. They might have been injured more or might even have died if they escalated the violence more. In examples where the imagery is really helpful in making the updated meaning sink in more would be where patients run the event on from the worst point to an image that symbolizes how they, for instance, were alive after the trauma and then resumed their former life. An example would be somebody who had a motorcycle accident and had an image while he was flying through the air of his body being shattered in pieces, which meant to him that he would die. And this man was also very involved in his church before the event, and it was an important part of his life that he now, after the trauma, couldn't really participate in anymore because of his PTSD. And he chose, and the scripts are developed together with the patient. The patient gives the ideas of what images would symbolize the meaning. I survived, I can go back to my old life, I can resume my life in the image. So he chose to assemble his body again in the imagery and then go to church and preach in his church like he'd done before the event. And that really helped making him feel that he really had survived and he hadn't died in the event. I already mentioned for people who've lost a loved one, it can be really important for them to have an image how they can carry the meaning of the loved one with them. So for instance, imagining sunshine as a symbol of the person they loved, and they can carry that image with them. So they haven't lost connection with the person altogether in the trauma, but they can still have them with them all the time. Another example is about being out of control during the trauma. Often people feel really helpless and feel that all control has been taken away from them. So in imagery, they can develop a script with the therapist that symbolizes to them that they actually are in control now. This could, for instance, include in violent assault or also childhood sexual abuse, for instance, that they can now control what what the perpetrator did to them, and they can interact with the perpetrator in a way that shows that they are controlled now. And that could, for instance, be talking back to the perpetrator, or in imagery sending him away in the past where they belong. Finally, imagery can also be really useful in changing persistent intrusions that may still persist to some level after we've done the memory work and the trigger discrimination. This imagery really helps people really experience that the intrusion is something in their mind and not current reality. So they could choose an image that they would translate their traumatic image to. So they could, for instance, change the intrusion to a benign image from their current life, change the size or the direction of the intrusive image, so like the perpetrator now running away rather than coming towards them, for instance. Or they can change the objects in an image, so for instance, the assailant, instead of holding a gun, holding a flower, to apologize to the patient. You can be creative, and it's really important that you choose with the patient together images that make sense to them, and that really bring to mind the meaning that it's actually an intrusion in their mind, and it's not current reality, and they can change the image in their mind as they like. Okay, so that means I will probably leave out some of the videos I might show you, but as we have this resources website, you will find, for instance, a video on the site visit there, and so I'll cut that bit, because I want to go through the final core procedures, which are the site visit, doing behavioral experiments, and the blueprint. And then there was a special request also to talk about rumination, because we made a distinction between rumination and intrusive memories, and how we deal with rumination. So I'll try to go through these points. So for us, the site visit is really a method to put the finishing touches on all the work we've done on the discrimination of triggers, because as you all said, the site is a big reminder of the trauma, and really going back to the site brings back that time has passed, things have changed like nothing else really. But also the finishing touches often on the appraisal work. So there might be something that we couldn't quite be sure about, like how the layout of the way the person's path was, and how long it took from A to B and so on, can be really seen in real life at the site, but we can't always do it in our efforts to reconstruct the memory. So just in terms of how much it brings home the message that trauma is in the past, especially if the trauma is quite a while ago. And it is really very striking that for patients, and they often say that afterwards when you've done the site visit with them, they really feel that the site will still look the same. Like they might think that all the blood there, all the people who are injured and so on, because that's what comes back in their intrusive memory. So for them, that's still the present in a way. We've worked on that with the updating, but then actually going to the site and seeing the site is quite normal and nothing bad is happening there at the moment can be very therapeutic. Nowadays we have also the internet and other ways to do virtual site visits, especially if the trauma happened in another country. For instance, we use Google Street View quite a lot, because you can really reconstruct where the patient was and where they went and how the trauma unfolded, and then look at the site from different perspectives. So that can be used for both when you can't go to the site, but also often as a preparation to the site. You can talk about what the patient is expecting to see, and then actually already see on Google Street View that it looks quite different now. And we find that really helpful, and we think it is really worth the extra time, because I appreciate it might involve travel time in addition to the site time you spend with the patient on the site. And we again, like as it's a session that has to do with memories, we should budget for spending at least like an hour or having an hour available on the site so that we can really take in how the site looks differently now, and that we can test out any kind of appraisals that the patient has been left with. For instance, that if they believe they could have prevented, let's say, a road traffic accident, actually going to the site and measuring out where they were and where they first saw the other car coming and the speed they were going, you can really see it wasn't possible to come to a stop in time. Or if they were running away from somebody, they may have felt they had to run several kilometers until they got to safety. But if you actually look at the site and where they were and to their home, it wasn't actually that far away when they got to safety. So that might take a bit of time. And we find that really for the patient it helps with the final sinking in. It's all over now. So we find it helpful. And we would also then do something for the patient to remember being at the site, so a photo of themselves as the site, as the final proof that they have survived and they can revisit the site. So we strongly recommend it. I won't show the video because there's videos on the resources site now that will help you. The site visit requires some preparation. We find it really useful to use Google Street View or Google Earth beforehand to practice the then versus now discrimination, so that the patient is prepared to use the discrimination as well when they visit the site in person. Of course, we would only plan a site visit in person if that's safe. When we're not working during COVID, we would aim to accompany the patient there. And also in the preparation beforehand, we would be careful to make predictions. What does the patient predict what the site will look like, what will happen there, so that we can use the site visit also as a behavioral experiment to check out these predictions. Really important to remind the patient to use trigger discrimination at the site and compare the site to what the memory tells them they were expecting, and really take in everything that's different now, checking out the appraisals they are testing. And it might not be easy for patients to do that in the first attempt, so you may want to also look at alternatives. The virtual site visit is very helpful, but sometimes it can also be helpful to have other pictures from the site that maybe the therapist could record and visit first to ease the step to doing the site visit. In times of remote working, you could also see whether the patient could go with a friend or a family member, and then we would give them some information that they can hand on to the helper, so that they know how to use the then versus now discrimination as well, and really help the patient be aware that they are now in the present, looking back at the site as it is now and take in the trauma is over. We have talked a lot about the memory work that we are doing in therapy. Let's now talk briefly about changing excessively negative appraisals and maintaining coping strategies. And you will find a lot of other videos on the website that go into much greater detail about this. But how do we actually generate the updating information when we are dealing with negative appraisals around self-blame, for instance, or high self-criticism, or anger? The general principle is that we would use the general style of cognitive therapy, a collaborative style, with the guiding principle of guided discovery. You want to get into the patient's head and understand how they see the trauma and its consequences from their perspective. And a guide to these appraisals are the emotions that people have, and that's why we're tracking what emotions they bring up in the memory work to really make sure we get the right appraisals. Once we have some appraisals, we would use Socratic questioning to widen the patient's perspective on these appraisals and consider alternatives. And this is really done from the perspective of curiosity. It's not like we're trying to persuade the patient that they are wrong in any way, but we just, in a kind of curious way, with the Socratic questioning, raise questions that will then enable them to consider alternative interpretations. And then we would use individual techniques tailored to the idiosyncratic meanings, whereby we always have to remember that some of the important information may already maybe only available if we know the details from the trauma. So information that patients are currently not accessing at the moment or not using that information when they consider the appraisals from the trauma. And when we've raised sufficient consideration of alternative interpretations, we can then also, with the patient, encourage them to gather evidence. This can be the discussion of evidence for and against in the session, but more importantly, experiential work. And behavioral experiments are really important there. And I want to illustrate this for patients who have an overgeneralized sense of danger and really perceive a high risk of trauma after they have had previous trauma. Mind you. So then the next point I wanted to talk about behavioral experiments, and they are especially important for people who have this overgeneralized sense of danger, where they fear they or their loved ones are at high risk of having another traumatic event. And what we're trying to achieve in the first initial discussion with them is for them to consider the alternative hypothesis that actually the world hasn't changed, the risk is the same as before, but their memory tells them the world is much more dangerous than they appreciated before the trauma. And that we can do by first of like letting in the Socratic questioning, coming to that conclusion with them. We often also look at like a little bit of a risk calculation, and there's a schema for that in the handouts. Again, I won't run through that, but actually just contrasting with like how often, let's say, they were assaulted with how many times they had left the house in the last few years while they were living at that address, can put it in perspective, because they subjectively feel the risk of being assaulted each time they leave the house is 80%, whereas if they do the calculation, they come out with something that's much smaller than 0.0. So that gives, but that's not enough. We need to make them experience that actually the risk is much less than they're expecting by doing behavioral experiments. And there's two aspects that are really important for. First of all, we need to look at the selective attention to danger, because somebody else mentioned that in your example, I think it was. There's a very much a hypervigilance for any sign that another trauma might be happening. And the example we had with somebody looking the same as the assailant is really also a result of the hypervigilance. They see somebody that looks vaguely similar everywhere, and that increases their subjective estimate of how many potential assailants are around. So we need to work with them at really realizing hypervigilance maybe is useful if there's a real danger, but in a case where they are actually being hypervigilant for this type of trauma is actually not helpful. It makes them more alert for danger, and also it can backfire. If you take the example of somebody who had a road traffic accident, who is hit from behind, and then constantly looks in the rear mirror, they might be very good at spotting anything that could hit them from behind, but they don't have their attention on the traffic in front of them. and actually might not be safer at all. It might actually be less safe to do this. So in order to increase the awareness that hypervigilance might contribute to that anxiety, we often do a simple experiential exercise in that, let's say somebody was assaulted, so we just leave a similar setup like here, we just go out of the door and stand by the roadside, and then for a short while ask the patient to really pay attention to any signs that a road accident might happen. And when they kind of put their attention to cues like brakes screeching and like somebody going too close to somebody else, or a pedestrian kind of stepping onto the road just before a car is coming, they will see, because this is not related to their own trauma, it's easier to demonstrate it with another type of risk, that actually they feel much more anxious when they've done that for a while, and they're suddenly much more attentive to anything that is a sign of danger. So their subjective estimate that accidents can happen also go up. And when we've kind of established that, then we can ask them what do they think, well, that might now mean about their own kind of hypervigilance for people who look like the same as the assailant, and they can understand, oh, this could also increase my feelings of anxiety and my feeling that I'm at risk. And then be willing to do behavioral experiments where they drop their hypervigilance. That's not that easy for them to do, so they might still slip into it, and that's why it's initially quite helpful to do the behavioral experiments while accompanying the patient, so that you can spot any safety behaviors and hypervigilance. So safety behaviors can also be very subtle, and often the patient won't tell us everything they are doing. Typical ones were like in an assault, for instance, crossing the road when somebody is similar, going back to your house, and some people wear special makeup or wear special clothes so that they kind of not, in their view, helps them to be less of a target for possible assailants. So it can be quite a whole range of things, and they will use their safety behaviors and their hypervigilance while they are out and about. So what we want to do is putting their predictions to the test. So if I leave my house, I will be attacked again. Put it to the test. So they have to be motivated to do that, of course, and so you can see the working up slowly towards them actually agreeing to do the behavioral experiment is quite important. And and that's pretty similar to other anxiety disorders, really. But there's one important difference that I want to highlight, and that is we have to really remind them of their using the then versus now, because otherwise they might actually confirm, like they might do the behavioral experiment, but it just confirms their impression that there are assailants everywhere. So if they then don't use the then versus now to see that actually the person who they thought looked like the assailant and look at them more closely, then to really find out they look different, then it actually has confirmed their belief rather than tested it. So that's the basic idea, and I think we also introduce, we find it useful, especially for people who have had more than one trauma, which kind of then confirms the idea that they are kind of special, that they attract risk. We're looking at the kind of continuum of risks that people are willing to take, and we ask them where were they before, so that maybe they were somebody who was actually quite willing to take risks, but now they have moved basically all the way here where they don't take any risk at all. And where would they like to be? Maybe they don't want to be such courageous as before, but maybe more in the middle. And we can ask them about their friends and family and where they are. To get the idea, it's a continuum. There is risk in everyday life. We don't want to deny that. But the idea that their memory has been kind of contributing to feel so at risk of another trauma, another horrible thing happening to them. I'll just, I think I have mainly said that already, so we kind of introduced the idea of that the perceived risk is different from the objective risk. The memory is an alternative interpretation. Work on stopping safety behaviors and do behavioral experiments first. Some we can do in this session even, but mostly out-of-office behavioral experiments where we do then versus now. I would really like to emphasize how many advantages out-of-the-office experiments have. They really help you proceed with the treatment much faster than you can if you just discuss these experiments from the office. For instance, when you're going out with a patient, you can identify hidden safety behaviors that they might even not be aware of that they are doing because they have become so much of a habit, so that you can then encourage them to drop it. You can also identify beliefs that the patient may struggle to verbalize in the office. You can find hidden triggers and practice the then versus now discrimination while they are doing the experiment to make sure the experiment is a success. Because if a memory gets triggered, that would create a sense of current threat and may actually then confirm them in their belief that the situation is dangerous. So we would be able to prevent it by using the then versus now technique. So it helps us test main beliefs that maintain PTSD. So for instance, if I don't use my safety behaviors, I will be attacked again. The out-of-office experiment can be an important stepping stone for the patient to be then willing to do these experiments for homework and build on the experience they had with the therapist initially. If they don't feel able to do it right away, the therapist can also model the experiment as a first step. That is not necessary for all the patients. For some, it can be really helpful if they have a very high expectation that a catastrophe will occur. They might find it is too dangerous to do the experiment themselves. But if the therapist models the experiment and the therapist observes that the catastrophe doesn't happen, they may be then willing to try it themselves. Now, in times of remote working, it will not be possible to accompany patients necessarily to the out-of-office experiments so easily. As a possibility, I would suggest that you could stay in touch with the patient while they're doing the experiment via your mobile phone and give them instructions while they're doing them, for instance, reminding them that they have to use the then versus now discrimination. This slide summarizes the risk calculation technique that we use to really start loosening the patient's belief that they are at such great danger of having another trauma. And it basically has the idea that we contrast how dangerous it feels to the patient to have another trauma like an accident, in this example 80%, and contrast it to their own experience of how often, for instance, they have driven down this road and how long they have lived there before, and calculate the probability from their own experience, like they only had one accident when they did 2,000 trips in the last 4 years, which gives a probability of 0.05 in this example. So whenever you do these calculations, it's much below zero, and this is a big contrast that patients start to think, or maybe their subjective feelings aren't a good guide for how dangerous the situation is, and to consider the alternative hypothesis that their feelings are driven by the nature of the trauma memory. And this then can also be a good motivation to engage them in the behavioral experiment and give them a try. You will see an example of this in one of our videos on the website on behavioral experiments. So this slide summarizes the core steps of behavioral experiments that we will also just observe in a minute in the video of behavioral experiments, just a few main points. So it is really important before we do the experiment to plan it in detail. We want to really see which problematic belief we're addressing in the experiment and agree in a situation that would be a good test. We want to also specify really very concretely and exactly what the patient predicts will happen. For instance, somebody will attack me, or I will have another accident, and do a belief rating from 0 to 100. Those of you who are more used to exposure therapy will see a difference here, that we are really going for beliefs rather than the level of anxiety that people are experiencing during the experiment. And we also need to be very careful to specify what the patient will do during the experiment and identify any safety behaviors that they need to drop and what they can do instead. So when you're then doing the experiment, I already said it's really important to remind the patient not to use the safety behaviors, use the alternative behavior you discussed, and to keep them in the present so that they can really take in that the danger they are expecting, the catastrophe that they are expecting is not happening. And really focus on that, testing whether it's happening or not, rather than focusing on how anxious they might be feeling. And afterwards, we would discuss whether the predicted outcome occurred. There is a behavioral record sheet on the website that's really useful for setting up the experiment and then guiding this discussion that you can download. And a nice feature as well would be if you can take some reminders of the outcome, like photos on your phone that patients can look at as really proof that they did the experiment and what they are expecting did not occur. And obviously, if they have any doubts that are remaining, if the beliefs haven't come down fully, then we do design a new behavioral experiment where we test the remaining doubts, and we also need to check whether they actually had dropped their safety behaviors. If not, we have to redo the experiment and design a test that would be more convincing to them. And then you can see this now demonstrated in the extract from the video. You can see the whole video on the website. And we're starting with where the therapist and the patients have already done the risk calculation, that have loosened up the belief that she is going to be attacked again. So this, I'll start this video now for when the therapist has already done the kind of risk calculation with the patient, that she overestimates her risk compared to her own personal experience.
Her therapist wants to help her continue to test her belief and discover that when she drops her scanning and other safety behaviours, she is safer than she thinks.
Okay, Lucy, so I'd like us to put this belief to the test a little bit, if that would be okay. Mm-hmm. If you were to go for a walk outside and we were to drop your scanning and, for example, leave our mobile phones here, how much do you believe that you would be attacked?
Probably about 60%, I'd say. Do I have to go alone to do this? Because I feel a bit scared doing that on my own.
Yeah, very understandably. How about if we went out together and I were to help you work on really dropping the scanning and dropping those safety behaviours to start with? How would that sound?
Yeah, that sounds good. I think I could manage that.
Great, that feels like something you're able to do.
Yeah.
Wonderful.
They fill out a behavioural experiment record sheet and leave the office. Lucy's therapist walks with Lucy to start with, helping her reduce her scanning. They identify other safety behaviours as they walk that they were not aware of before. For example, walking close to the roadside of the pavement so that she cannot be trapped by anybody. They work on dropping this too. Men who look similar to Lucy's attacker are a trigger for Lucy, and when she sees a similar looking man, her trauma memory is activated. The therapist encourages Lucy to focus on what is different now compared to the trauma. This is a technique they have practiced in previous sessions called stimulus discrimination. When they both agree Lucy knows how to drop her safety behaviours, Lucy is encouraged to walk down the street alone.
Okay, Lucy, well done. How do you think that went?
Yeah, it went okay. Nobody assaulted me.
So it felt about 60% likely that you'd be attacked, but you weren't?
No, I guess I was being a bit careful not to get too close to any of the men. Maybe it would have felt a bit different if I was to get a bit closer to them.
Right, okay, so well spotted. It sounds like a safety behaviour crept in there. What do you think we would need to do then to really discover whether or not you're safer than you feel you are?
I guess I would just have to try and get a bit closer to men.
Right.
I feel a bit nervous about that, but if we give it a go, I'll see how I feel.
I think that's an excellent suggestion, and let's think about how we could do that now.
Lucy tries the experiment again, this time approaching a man she does not know and asking for directions, discussing the experiment and consolidating the learning.
Okay, well done, Lucy.
Thanks, that was a pretty big step for me.
Yeah, it was, wasn't it? Can we come back to the behavioural experiment record sheet that we started filling in and have a think about when you dropped your safety behaviours, what actually happened?
It was okay. I wasn't attacked even when I went and approached somebody. And yeah, I guess I was much safer than I felt I was going to be.
Right, that's an interesting point. And what do we learn from that?
I guess my feelings of danger are sort of being guided from the memory of the trauma, and I'm not actually in as much danger as I feel I'm going to be.
Right. I think that's an excellent point, Lucy, and one we should definitely write down. Before we do that, right now, if you were to leave the house on your own, not doing your scanning and your other safety behaviours, how much now do you think you'd be attacked again?
Maybe about 30%.
30%, so that's really come down today, that belief, hasn't it? What would we need to do you think, to really keep putting that to the test?
I guess I could test it out just this afternoon after this session. I could try walking home on my own rather than calling someone to come and pick me up.
I think that's a great idea if you'd feel able to do that. Perhaps we could set that up as another experiment right now.
Yeah, okay.
Lucy sets up more experiments to keep testing her belief for homework.
Yeah, so again, this is something where it's kind of builds, one experiment's built on the other, so we kind of make a harder, more strict test of that, the idea that they are going to be attacked again. And sometimes we need to also really look at the very idiosyncratic evidence of that the patient has for their risk being so high. And I just wanted to show you like what we did with the patient my patient you've seen on the video. So she was very, very, very avoidant of leaving house at all, and we had already done quite a few kind of experiments going into Camberwell and kind of standing by the roadside, watching people go by and testing the belief she's going to be attacked. But and that had gone all right. She had been able to drop her hypervigilance somewhat and also her safety behaviors. But we then she came to the next session saying, well, actually, she was really worried about her sweating because she tended to really visibly sweat and her face kind of looked wet. And it might have been the anxiety, or it might have been also related to menopause or something. I don't know why but she was really visibly sweaty sometimes. And she felt extremely vulnerable when she looked so sweaty, because she felt that this would mean if there was a potential attacker, they would single her out because she looked like an easy target. Because she looked so sweaty and a bit unwell. And so she felt that she couldn't really do the experiments on her own, because she would look too vulnerable and people would single her out. So we then decided, and she wasn't willing to do that as a test, even with me accompanying her. So we decided we'll do the following. I was going to be the one looking sweaty, and she was the observer, like we often do with agoraphobic patients as well, where the therapist is the one doing the behavior experiment and the patient initially observes before they try it on their own. So basically, I needed to make my face really look wet. I had lots of water, and I also took a water bottle along so that I could always freshen up to be really nice and sweaty looking. And her prediction was, and that was really interesting, that she was 100% sure I was going to be attacked, but she was also 90% sure she was going to be attacked too. And that was interesting because we had, with the previous experiment when we had gone down, that was already had to come down further. But the reason was that in the previous behavioral experiments we done, I wasn't incapacitated. So but now that I looked so sweaty, I couldn't really help her. So that made her even very vulnerable again as well. So we just went through Camberwell again, like we had done before, but this time looking really lots of water off my face, and the patient actually confirmed that I looked really sweaty, so as sweaty as she visualized herself to be when she did that experiment, when she was anxious and was out in public, and she was observing how other people responded, and it is really interesting that people don't pay very much attention to you. You will have all had that experience. So actually 90% of people minded their own business, actually didn't even look at us, so didn't notice. Then she estimated it was about 10% that noticed my sweaty face and looked and kind of a bit puzzled, but then quickly looked away because it's a bit embarrassing to stare. And some then quickly looked back, but then quickly looked away again. But as the goal of the experiment was to test these predictions, the important outcome was that wasn't what we were concerned about, whether people look or not, but we were concerned about being attacked, and nobody attacked us. And then similarly to the other experiment we did in the bus that she described, there was also another nice thing happened. Like there was something on the pavement, so she stepped briefly on into the road, and then there was a man coming the other way, and he called out to warn her and say, "Olaf, don't come back on the pavement, it's dangerous here, the buses might hit you." And she couldn't believe it because she, at that stage, still felt every man on the road could potentially attack her, so that there was this person who was trying to rescue her was a total revelation to her. So that was a nice side element, so she kind of started to really create more doubt in her original interpretation. Anybody could attack her. So she simply concluded that prediction was wrong, and it wasn't down to 0 the risk that she was going to be attacked, but you see it was a big change to 20%, so that she found it really convincing. And it was then when she was actually happy to try it on her own. She did then experiments like going to a local shop, because she would often actually not cook dinner for her son because she couldn't face up to shopping. So she decided she was going to cook dinner for her son. She went to the local shop, and then when you wait to pay, then there's often like somebody standing behind you. She went to IKEA, I think, with her sister and so on, where there's like also queuing and people behind you. So she was, I think this was a crucial experiment that kind of brought home the message, even if I look sweaty, it doesn't mean I necessarily be attacked, and it's worth doing these experiments. And she also kind of concluded I worry too much, so that those were her own words. So that's kind of another example where the experiments build on each other, and we need to maybe work on quite a few of them before we can actually, the patient is willing to test them out on their own, because for them subjectively, this is the true risk. It feels like 90% or 100% that they're going to be attacked again. Any questions or remarks from your own patients about behavioral experiments with PTSD? Okay, so then I'll move on to so how does the memory work for people who have multiple trauma? And this is a vast majority of people have more than one trauma, or often many traumas. We can use the same techniques effectively, working on one trauma at a time, but we're looking for some economy here. We would often see that the traumas group into common themes, like traumas that affected trust in other people, trauma that led to extreme self-criticism, for instance. And we would then try to find a trauma to start with, and that is often the one, and we discuss it with the patient collaboratively, which one they start with. Good ones to start with would be traumas that are commonly we experience, so the ones that lead to the most distressing re-experiencing symptoms at the time, or traumas where one of these meanings that trouble them at the moment emerged. You will find more detail in another video on the website about considerations about choosing which ones to start with. So we would then start with that trauma in the way I have described, and we would then also see whether when we're working on this trauma, maybe elements from other traumas may come up when they're doing the reliving, which will give us a hint then which other ones to work on. And if once we updated the meanings of this trauma that we're working on successfully, we would hopefully see some generalization of effects. Re-experiencing of other traumas that have related meanings should also decrease. And we would then also look at new meanings emerging that helps us with further updating hotspots. And so we would work our way through the various traumas until we have addressed the main meanings that trouble the patient at the time, and that lead to the sense of current threat, and also all the traumas that still are re-experienced. For patients with multiple trauma, choosing carefully rebuilding your life assignments is especially important to give them the sense that despite all the trauma they had, they can rebuild a life that's meaningful and enjoyable. We also have to look carefully at the maintaining behaviors. For instance, if somebody has had really many events that were traumatic, chronic hypervigilance can occur. That kind of makes sense if you have so many events happening, or if it was actually useful, let's say, in soldiers in combat situations. Obviously, it is really very helpful to be chronically hypervigilant. And we have to work with them and being able to drop this chronic hypervigilance and realize they are in a safe situation now. They are in a civilian context where chronic hypervigilance is actually not helpful, and actually in some cases can increase the chance of further trauma. So for instance, we had, as an example here, we had a young man who had multiple traumatized, and some of the trauma involved being attacked by police officers. So this young man was very chronically hypervigilant whenever he saw a police officer, and sometimes then when he saw one would run away, which then attracted the attention of the police, and he experienced further abuse from them. So really seeing how the behavior is understandable, but also enable the patient to learn to drop it. There may be a few other techniques that would be useful for patients with multiple traumas. For instance, a positive data log can be especially useful for people who have high self-criticism and very low self-esteem as a consequence of repeated abuse. A prejudice model that you find illustrated in one of our videos is also very helpful for them, and surveys, again, are a very useful technique for people with multiple trauma. Okay, so those were the core procedures targeting the trauma memory and the interface between appraisals and memory that I wanted to present today. But let's now move on to address your question about rumination. Yeah, so we mentioned at the beginning that we see rumination as a different process from intrusive memories, although one can trigger off the other. So somebody might have an intrusive memory and then start ruminating about how unfair it is that this happened to them, how their life is ruined, and so on, and vice versa. When they kind of ruminating, they might also have memories being triggered. And we could think of rumination as unhelpful pattern of thinking that kind of keeps going on around in circles, and it really is about questions where there's no good answer to, like what if, or about undoing the event in some way, like if I hadn't left that house that morning, I wouldn't have been hit by the car or something. And so that's not, it might feel initially even helpful. Some people, Adrian Wells talks about positive beliefs about worry. You could say that maybe some people who also find it helpful to think about the event again and again, because they have the belief that it would be helpful if another trauma happens. So let's say somebody in a road traffic accident blames themselves for what happened and then thinks about what could I have done differently, and I could drive slower, or I could stay on the other lane or whatever, and that would be a solution. But in reality, what we find is, at least when it is a problem, like in our patients where the rumination goes around the same questions without an answer again and again, we often see it as a way to not engage with like the problematic means and the worst moments of the trauma. It's often around making it undone or about the consequences of the trauma, but not so much about the worst moments that we focus so much in the hotspot work. And that's similar to what Borkovac and others have described in worry, that it can be like an avoid strategy as well. So we see that in our patients as well. So what is rumination is often also connected to certain appraisals of and responsibility. So it is my fault, my contribution really was so bad that it made the event happen or made it worse. It can be about humiliation, so what the perpetrators did humiliating things to you, and this kind of ruminating about the sense of humiliation we see, and unfairness. Those are the most common themes. So how unfair it is that I have all these injuries still to live with, and the person who caused an accident actually came out with very minor injuries and is now fine. So I said it can start intentionally because people really want to find answers to these questions, but it then kind of often quickly spirals out of control. They feel it kind of, there's no end out. It's kind of going round and round and round, and they get more and more depressed. It's a link to the feelings of depression and despair and hopelessness, really, often. So once it starts and then kind of spirals into this uncontrollable, what they perceive as uncontrollable, they find it really hard to stop. And they will describe that, well, an external stimulus, like a phone call comes, and then they can stop. But if they just sit there on their sofa and ruminating, they can't really kind of get the energy to really pull themselves out of it. And our kind of simple idea about this is that really what we want to do is we want to enable the patient to spot this process early, so to nip it in the bud. So when it's just starting, kind of recognize it and then disengage when it do other things that take you out of rumination. And many patients who ruminate a lot will spend, like often describe that it kind of gets triggered very often in periods of inactivity. So let's say they are already quite depressed, so they are not very active. So they may sit on their sofa, and initially you may think they do like read something, but then quickly the rumination. So periods of inactivity are a risk for rumination. And so the specific technique is like to spot the rumination early and then disengage. What should say though, that we've also found if we do the memory work successfully, and that's why we're kind of doing the updating as quickly as we can, is that this can also reduce the rumination without extra interventions. But there are some people who are so engrossed in that rumination and really spend a lot of time invested in that. So we have people, for instance, who will search the internet endlessly about, especially if it's about unfairness. So somebody who has a medical trauma might spend the internet looking for lots of similar cases where people were maltreated by their doctors, and that then confirms that belief more that it's so unfair that this happened to them, and may then kind of end to really long periods of time where they don't do anything else at the expense of others. So what do we do? So first of all, we actually educate people about the discrimination of the differences between rumination and intrusive memories. For them, it's all memories, but then to really notice, oh, this is not really what happened in the event, it's not a memory of the event, it's more like trying to make sense, or trying to kind of improve the outcome in your thoughts in some way by thinking, by asking yourself these questions. And then we would talk about whether the rumination has been helpful, and some people will really think, oh yeah, it has helped them in some way, but we then talk it through, like, how does it make you feel if you ruminate for a while, or actually I actually feel worse than I did before, and really link in their own experience, like, has it made them feel better? And yeah, so it seems like useful, and they think they might find a solution, but actually the questions they are asking, there's no answer to, and it can't be undone. So we can't now go back and change their behavior at the time, for instance. And then we would we find it helpful, and the patients like that. We look at the first sign of rumination and then label it, and people find funny names like my spaghetti thinking or something like that. It's really the sides of this jumbled up thinking that they get during the rumination. And when they then find themselves in the first kind of phase of it, they start, oh, I'm getting into rumination, they will then label it, say, oh, this is my spaghetti thinking, and use that as an impulse then, or as an incentive to then do something else. So usually, again, some physical activity. It could be something simple like making yourself a cup of tea, or it could be like go for a walk, or kind of jump up and down, or something that they do your exercise, something active that they can engage in, which will take their mind off it, or they can call somebody and talk with them to get out of the state. So it is really about finding the best way for them to be able to disengage. And we also need to be, as therapists, that's something that's quite interesting to learn. There are some patients that will get you involved in quite a lot of ruminative thinking. So you're trying to work, let's say, ask them about what the worst moment is, but they will go from one to the other into this ruminative loop. So we can also, when we spot it in the session, feed that back to the patient and say, well, let's stop for a moment. What do you think was going on? Do you think that could be your spaghetti thinking now taking over? And so that we can model the interruption and then getting on with something more productive to do it. So you need to warn patients before that you have the permission to tell them, because we're obviously also working very hard to make them feel that we understand them and we are there for them. So if we get the permission, then we can interrupt them. And patients find that helpful, because they get themselves quite frustrated that they're always in these cycles and can't break out of them. So that's the basic idea. We have also in some patients successfully used Borkowicz's worry chair idea. And the idea, most of you will be familiar with that, which is the idea that it's difficult to stop rumination or worry, but it's easier to say, I'll postpone it. I think about it at 5 o'clock this evening, and there's a special place in the house where I'll do that. So for some patients that works well, but we have also had patients who taken that again as an instruction that they have to ruminate. So they might have actually felt quite good the whole day, but they thought, oh, at 4 o'clock I have to sit on the chair and worry a lot. So we have to tell them, well, if you don't feel that like this is something that you want, that is actually something you urgently want to think about at the time, you can also continue with your other activities. But the idea of postponing is quite good. And then they find when they actually go to this chair and then say, oh no, I'll start ruminating now. They find it actually much harder to get into it, because they get from it's something that they actually might not have been on their mind at that moment, and then they find it's harder to bring it on. So for some patients that can be useful, but it's a bit of trial and error, I must say, in this. We haven't found exactly to predict who will do well with that intervention. but some really like it. I think I've already mentioned sitting around and doing nothing as a risk factor. So in a way, the reclaiming our life activities that we are doing and really putting more structure in the day again and having regular activities also reduces these risk situations for rumination quite a lot, because they have something to do and something to go to rather than sitting at home doing nothing. And this is again similar to the worry interventions. Really having a conversation about what are the advantages and disadvantages about thinking hard about certain questions. And if it's something you can do something about, it's a useful thing to do, just like problem solving. But if it's something that actually you can't change, it only has disadvantage, because it only makes you feel worse, and you kind of feel even more stuck than before because there is no solution. And to explicitly discuss that with patients can be helpful. And then another idea taken from Ed Watkins, who does a lot of focuses on rumination in his treatment of depression, is similar along the lines of what can be done. So instead of these why questions, why did it happen to me? Why did my life have to be ruined and other people are living happily? Is again the idea of making it concrete, the thinking, what can we do? And so, for instance, you could say, why is my life so ruined? You can think about what can I do? How can I get involved in exercise again? How can I inquire about, of course, how can I get to work again? And working on these concrete steps then helps them to think more concretely, so that counteracts the abstract rumination, and also helps them move on with their lives, which then makes the questions they are worrying about or ruminating about much less salient and much less urgent for them. So I think these are the main kind of methods that we would use. But I think the most important one, actually, from what we do is kind of really spotting the process early and interrupting and labeling it, and then move on to other things and be more active. Final core intervention, which is the blueprint, we find that really helpful, especially as we have observed again and again that it is not uncommon that people have minor setbacks around anniversaries, for instance, or also, unfortunately, other bad things happen to our patients. It's unfortunately the case that sometimes they have another trauma or a near trauma or something like that, and which then can kind of bring up intrusive memories again. So these are the questions that we ask the patient in the blueprint for PTSD. And it could be, it is about how the problems developed, really kind of summarize their understanding from the treatment of what kept their PTSD going. And it's sometimes quite interesting what they write there. Sometimes they leave out things that we, for our therapists, find really important, so we can help them to complement what they've written, what their unhelpful thoughts were, how can they further build on what they learned. Often they are left with needing some rebuilding of their life to do, so they may not quite back to all the activities that were important for them before, or they're still kind of training for a new job. They need to apply for a job and things like that. And actually, I just realized we now see more setback here than another traumatic event. But we ask about them, what if they had a setback, and we talked about anniversary with them, and really then remind them to use the same strategies that they used for overcoming this trauma now for a setback, or even if something else negative would happen to them. And we usually do that in kind of the last session to summarize. Some patients don't quite finish it then, and then we would do it, and we usually do monthly follow-ups, 3 monthly follow-ups, so that we can finish it off then. But we find that useful in patients. We encourage them to read it once a month in the first few months to remind themselves of all the things that they have learned. And we would also send them home with a printed out version of their narrative with the updates in, so that they can also consult that if they feel a setback coming up. As this workshop focused on the memory work that we're doing in PTSD, we have had less time to focus on different appraisals that lead to different emotions, such as anger, guilt, or shame. You will find videos on these themes and also on useful techniques that we use to address various appraisals on the website. So here are some examples. Evidence for and against, we mentioned, that is the basic cognitive strategy, to look at for and against evidence for the patient's appraisals. Behavior experiments, we talked. Looking at advantages and disadvantages is really important, for instance, when we're looking at coping strategies such as rumination or thought suppression. The patient has seen advantages, but we were able to show them in our discussion that there's also disadvantages. Pie charts, you will see a video of how to do them. As you had an example in the shame video already. Surveys are really useful for people who are very ashamed. We talked about information from other sources being important, statistics, significance others, and sometimes you can bring a person, an expert, into the session to explain it to the patient in greater detail than you as a therapist would know. Guided imagery we talked about, and then positive data logs are other examples that you find on the website.